ओके क्या कहना है?
We are live, sir.
Yeah, it's 9 a.m.
The audio is not playing. Kshitij or Agnivesh?
Sir, it has been purposely muted
Okay,
for some reason.
Thank you, Dr. Agnivesh. We can start the meeting.
Agnivesh, can I be the host?
Yes, sir. Please go ahead, sir.
Yeah. Good morning, all. Welcome to the 6th clinical meeting. We had so far 2 physical meetings, and the remaining 4 were online meetings of Bombay Orthopedic Society this year. Bombay Hospital is an excellent host. We all know about it, and they have excellent cases which are lined up for today's clinical meeting. With this, I welcome you all, and we will start the meeting as soon as possible. The first presentation is from Nilen. Am I right, Parag? The co-host, unmute yourself. My co-host is Dr. Parag Munshi from Bombay Hospital, and we have excellent faculties and excellent cases for presentation, including the host institute, and there are 4 cases from outside the institute by our Bombay Orthopedic Society members. Can we start, Parag?
Yes. So we've got Dr. Nilen Shah. We've slightly tweaked the order of the play. Dr. Nilen had to go away for a personal reason. So he's going to start with his 2 cases back to back, and then we follow with the rest of the order on the list. So Nilen, when you're ready, we can kickstart it.
The request is to all the participants, raise your hand before you want to put a question or give your opinion. Thank you.
Good morning. Thanks, Sangeet. Thanks, Parag. Thank you for accommodating me. Can you all see my screen?
Yes.
So I'm presenting a case of a periprosthetic fracture after a knee. So this was a 47-year-old lady, hypothyroid, severe bilateral knee pain, severe varus, 28 degrees on the left side, 23 degrees on the right side, walking with a predominant medial thrust. Life had become a misery. And I decided to do a bilateral cruciate retaining knee in 2016. And these are the post-operative radiographs. She was all right till around a year. Unfortunately, had a fall and sustained this fracture. Quite a significant domestic fall, twisted. There were no signs of infection, all labs normal. Unfortunately, I did this. As Dr. Mukhi would probably say, this is a day one failure. I mobilized her non-weight bearing, but lo and behold, the fixation failed. I did probably a better job the next time around, refixed it with a longer plate, added a few cerclage wires, thought that a revision fixation had a high risk of infection. So added these calcium phosphate stimulant beads with antibiotics. She seemed to be doing well. 1 month post refixation, walking. 2.5 months, partial weight bearing mobilization. 1 year, unfortunately developed infection, although the fracture looked healed. Discharging sinus from the plate area. The culture showed E. coli. And I had no option but to take the plate out. And when I did that, I found that the knee also was looking infected. So I removed the knee as well, put this cement spacer inside. Tissue culture was E. coli. Antibiotics were given as per sensitivity. So this is 2.5 months. Most of the calcium phosphate beads have got absorbed. ESR CRP tended towards normalcy, wound healed well. And secondarily, I did this, which is a custom prosthesis, hinge, SROM noils. And this is a 3-year follow-up. Seemed to be holding well. A lateral X-ray, both knees doing well. These are the healed scars. And she has sent her gait video, even descending and ascending stairs without too much of a problem. So take home message, periprosthetic fracture is a serious condition, requires meticulous planning and execution. I came across this article, which is to be published in Journal of Arthroplasty, probably this month. They have divided the fractures into 3 types. Fracture proximal to the flange of the implant, where you may put a lateral plate or an IM nail. If the fracture is distal to the flange, if the main beak is medial, then you put a dual plate. If the main beak is lateral, only a lateral plate may still suffice. And if it is unfixable or a loose prosthesis, one must do a revision or a custom implant. Thank you for your attention.
So can we discuss?
Can I start?
Yeah.
Yeah,
Can you
sure.
discuss the first
Yeah,
case? Can you go back to the X-rays, day 1, which you mentioned? Dr. Mukhi will jump on you. Is Dr. Mukhi there?
Yeah, I'm there.
Yes, sir.
No,
Can you explain this day 1 failure?
Yeah, I want an X-ray before this. May I have the X-ray before this? No, before this. No, before this. This. Now here you see, this is in.
The right one has fractured.
No.
The left
The right
one.
one is prone to get fracture.
Okay.
Because of the hyperextension. Can you see the tilt in the component?
Yes, we can.
Yeah. So this was the site which has fractured because of the malpositioning of this component. And this component, I feel, is giving the laxity, hyperrecurvatum. And that is why she fell. Coming to the next X-ray. Second, please. This is taken in flexion. Right. Now, this fracture, to be safe, you require dual fixation, either with nail plate, intramedullary, or dual plating with all the synthetic bone of phosphate inside with antibiotic loaded to take action primarily also. So go to the next X-ray. Here, the plate is too short, so it is not going to have any good fixation. You have to use a longer plate, and if possible, I prefer an intermedullary nail.
No, go back and stay on the same X-ray. Here, probably neither it is a bridge plate, neither it is a compression plate.
Yeah.
So and as Dr. Mukhi has pointed out, it is a very short plate if you have used in a bridging mode.
Yeah.
You can see the working length between the two screws. It is too long for the length of the plate. And that is the reason he is saying the length of the plate was too small. Probably a good interfrag screw and a plate which is about 3 holes proximal to the end of the fracture would have been ideal here in this case. And second is the rotation of the distal fragment, which has not been addressed. And hence, probably it has led to all those. Dr. Mukhi, sir, you said it is a hyperextension of the femoral prosthesis which has led to this fracture.
Yeah.
So, and Dr. Nilen also, is there a particular reference to the configuration of the fracture if you have a hyperextension of the prosthesis, or where you have the impingement of the flare?
There's no reference for that. It's very difficult to observe that. They all take the X-rays in flexion. And this was the only X-ray which was taken in standing. But had it been taken in hyperextension, you would have got it.
Dr. Mukhi, we all know that notching leads to that fracture.
Yes.
But you are saying exactly opposite, where there is no notching and still you can have a fracture.
Yeah.
Is there a reference to that?
No reference.
Sangeet,
Yes.
if I may say that I fully accept what Dr. Mukhi is saying.
Nilen, but in one view, you cannot comment on that. This may not be proper dead lateral view.
No, it is not a dead lateral view. What I want to say is that there are a lot of knees which have around 5 degrees of hyperextension, as it is being seen here. But periprosthetic fracture is not as common as Dr. Mukhi would want us to believe, just because of hyperextension. So I fully accept the fixation failures, but I would say that as this is an hyperextension, that is the reason she is fallen, and that's the reason there is a fracture. I would take that with a pinch of salt.
Okay, and go back to the second X-ray. Before I ask, I think Dr. Mohanty has joined and he has a comment. Before I ask him, can you go to the second X-ray? Second surgery, I mean, second post-op, where you have put a longer plate. Okay, again here, the same thing. The length of the plate is smaller for the working length. Of course, at this stage, patient had a different situation. But here also, if the patient would not have had infection, probably even this would have failed in a expected time. Dr. Mohanty, your comment, please.
Just wanted to, add to Dr. Mukhi's comments that if there is a notching less than 3 millimeters, there is no increased chances of periprosthetic fracture. Notching more than 3 millimeters, or when you can go until the medullary canal, that is the time that there are increased chances of periprosthetic fracture. One needs to put a stem extender on the femoral side. Otherwise, one need not put a stem extender femoral side if you are not violated until the posterior cortex of the femur.
You mean notching of the anterior cortex by 3 millimeters?
Yeah, less than 3 millimeter, there is no increased chance. You can do normal rehabilitation. No need to put stem extender, and that literature so doesn't lead to any periprosthetic fractures.
So here exactly opposite has happened. So probably it is unrelated to the hyperextension of the distal femur.
Yeah.
It is the instability.
Yeah.
I'm talking about the instability. I'm not talking about notching.
Okay. Aditya, your comment?
Sir, I kind of agree about the malalignment, but my question is whether bicolumnar plating at that initial stage would have solved the problem.
No. So the issue is you have to follow one principle of fixation. Either you use a bridge plate or use a compression plate. Now, if you have to use a compression plate, you must, if you're using a shorter plate, you must fill up all the holes of the plate. That is, you have to put an interfrac screw. Can you go back to the first X-ray? So this long oblique fragments must be fixed with interfrac screw, and then you can use a shorter plate wherein don't leave the holes empty. Try to fill up as much holes as possible, and at least two or three screws proximal to the end of the fracture would have been an ideal implant. If you get a good reduction on the medial side, probably the second plate is not required unless the fracture is too low at the level of the prosthesis or below it.
That is, I think, what the current article is suggesting, that if the beak is medial and the fracture is close to the flange,
Yes, sir.
then you must add a medial plate. If the fracture is well above the flange, a lateral locking plate, a bridge plate may be sufficient.
A single plate must be sufficient.
A single plate may be sufficient.
And number two, if there is a medial comminution, then it requires an additional medial plate. The other two conditions where one should put a medial plate.
And third is osteoporosis.
Yeah. Sir, one more question. When you plated the first time, do you change the poly
No, I didn't.
to the knee?
Any reason why you have asked that?
Sir, so I did a lot of, so when during my fellowships, I did a lot of work, and they always said, whenever you're doing anything to do with the knee, even if it's around the knee, because it's violating the principle, the part that can be changed easily is the poly, and that could lead to remnants of infection. So I was wondering whether changing poly was a part of the principle during the initial plating phase.
Dr. Mukhi, sir?
Yeah, you have to change, and you can find out the distance between the tibia and the femur. It is opening on the lateral side. And this is a non-weight bearing X-ray. You take a stress X-ray and you'll see the lateral laxity. Do you observe that gap?
At what duration she had a fracture after the index surgery?
See this gap and see this gap.
This was 1.5 years after the index surgery.
So at 1.5 years, will you change the poly? Mohanty.
Unless it is infected, we don't change the poly. Because, it will be extensive surgery. Then you have to extend your incision, you have to expose the joint, dislocate the joint in order to change the poly. So, because it's a fracture surgery, so your incision is lateral or maybe anterior, but why you are trying to extend the incision till, down to the joint, dislocate the joint, exchange the poly. So, there are high chances of infection again. So, it should be restricted to fracture fixation only.
Dr. Nilen, what would be your incision in case, as Aditya says, you have to change a poly in this situation or in this case?
In this case, 1.5 years post-primary, I would definitely not change the poly, despite what Dr. Aditya is saying.
No, we have discussed that. What would be your incision? Now, for the plate, you require a lateral incision, and for changing the poly, you require a different incision. If you have a situation like this, where you have to change a poly, what would be the ideal incision? 2 incisions, single incision?
Then what I would do is, I would take my original total knee incision, change the poly, put the distal screws of the plate from that incision, and take an additional lateral incision.
A MIPO type.
A MIPO type, if I have to change the poly.
Okay, fine. So, good case, Nilen. Parag, can we move to the second case?
Yes, we move ahead. I think Dr. Nilen is presenting the second case as well, and then he has to leave. Is that okay?
Yeah, your comments, Parag, and conclusion about the case.
So, I mean, 2-3 glaring examples or glaring lessons to learn. One is the primary fixation has to be of an adequate length and adequate stability. I think that was the starting point where things started going downhill. And as you rightly said, even the second fixation we could have improved with a longer plate and with a better stability. No amount of stimulant beads, etc., are going to supplement for primary unstable scenario. But, kudos, he's got off in the end with a good outcome. The patient must have spent a lot of money and has gone through a lot, but eventually she's landed up with good function. So, that's the bright side of the whole thing. So thank you for this case.
Dr. Nilen, thank you for showing a complication which has, it's a good learning case for us.
Thank you. Thank you. I thought that we must show our complications.
Yes, thank you, Nilen.
So I must thank Milind for getting X-rays for this patient. So this was a 68-year-old obese lady, bilateral knee pain, left more than right. She underwent staged total knees by my colleagues. So this was the left side, seemed uneventful. Then in February 14, she underwent a right total knee, posterior stabilized. She had a persistent discharge from the right knee. The treating surgeon had advised DARE, which is debridement antibiotic and liner exchange. I would point out this anterior synovial shadow, which is a subtle sign of infection in a lot of these knees. She refused this. She persisted on taking Ayurvedic treatment, pain, swelling, and raised inflammatory markers. So the treating surgeon, 6 months post total knee, did this articulated spacer. The growth was candida and appropriate antibiotics were given. The serial X-ray showed that this articular spacer seemed to be failing in varus. In Jan 2015, there was persistent infection despite the antibiotics, and the treating surgeon did a stage 1 revision. Again, the culture was candida. This was in Feb 2015. In April, these were the X-rays. The inflammatory markers settled to a large extent. And then she underwent this procedure, a stage 2 revision with an RHK. And these were the radiographs. She seemed to be doing well. But the sinus recurred in 2018, put on oral antifungals, continued for 2 years. She presented to us in March 21 with this intertrochanteric fracture, which I fixed with a DHS. In June, the sinus had increased. There was pain, swelling, unable to bear weight, inflammatory markers had raised. Again, an intervention became mandatory. So these were her radiographs, and she had an infected revision hinge knee. At that time, I came across this article which mentioned irrigation, debridement, and implant retention for recurrence of periprosthetic joint infection following 2-stage revision total knee arthroplasty. And where they said is that a liner exchange in well-fixed implants may be a reasonable idea and a lesser procedure. So I took her up for surgery with that, thinking that the implants may be stable. But when I opened it, there was frank pus, grossly loose implants. And again, I had to take out the implants, put a static spacer and cement beads. Some difficulty in closure of the wound because of the previous infection in the sinus. Did vac dressings. The wounds practically healed. She didn't have much pain. Range of movement 0 to 30, shortening, inflammatory markers settling. This is the current situation. Does walk a bit. What next? Leave alone, repeat 2-stage, fuse it, amputate. I am tending towards fusion. I have not used this.
Hold on. Nilen, hold on. Can you go back to the last slide? How is the hip fracture at present?
Hip fracture, I don't have an X-ray of that, but she is not symptomatic.
Heyman, are you there?
Yeah,
Unmute yourself.
I'm here.
Yeah. What
Yeah.
would be the best option at this stage?
In view of so many things, I would agree with Nilen. I think we should give her for fusion and with a heel raise. Fusion. Those people who are immunocompromised and elderly, I would tend to go for fusion. It is a one-stage procedure and does well. I tend to do it with a LRS and 2 cross 6.5 screws. And I've done a few and they seem to be doing well. It's good union.
Girish, Dr. Girish Devnani, are you there?
Yeah, Sangeet. Fusion would be the safe option because there is no way with the Candida infection, which has flared up a couple of times, to know that it's fully eradicated. And rather than risking an amputation, I would say fusion, but the risk of amputation still persists because even with a fusion, you may not get the, if the infection is persistent, it may not fully fuse up. So, and the soft tissues are a big concern here because one more surgery, how much will they be able to tolerate that onslaught? So, at the back of the mind, the amputation option still is lurking in the background. So that the patient and the surgeon should be aware, I think. But yes, fusion rather than going for 2-stage.
Harshad, are you there? Harshad?
Yeah,
Dr.
I am here.
Harshad,
I don't have a separate opinion on this. Fusion is the best option.
No, in such situation, probably individual experiences of each one of us is very few.
Yes.
And we have to address the bone loss or probably a segmental defect, which is as huge as 3 to 4 inches. We have to reconstruct that and then aim at a fusion.
Sir,
Yeah.
my feeling that we will not be able to get that much length because to subject her back to a procedure which involves limb lengthening or interpositional graft and then getting that to heal with an internal implant is going to be a very, very big problem. Now you put an Elisa on and lengthen her for 4 inches. I don't know if she's going to tolerate another 8 months of external fixator with all the problems. I think you have to accept the shortening, and we are doing it as a leave to amputation, something which we are trying to salvage a bad situation to a less bad situation.
Shubhranshu?
Yeah, just one thing, Nilen, is it diabetic? The patient is diabetic?
Non-diabetic.
Okay. Just a couple of points I just wanted to highlight from the beginning. Number one, when there is a discharging wound present, DIAR should not be done. DIAR is contraindicated in presence of a discharging wound or a sinus. So first suggestion by whatever the surgeon, one should not follow. DIAR has to be done in a closed wound and within 3 to 6 weeks of the primary surgeries to get the maximum outcome. Number two, when there is a Candida infection, one need to treat this patient minimum for 6 months in consultation with your infectious disease specialist. Candida infection is very resistant, all the fungal infection. It has to be treated with 6 months. And the cement which you put as a spacer, amphotericin B and variconazole, these are the 2 antifungal agents needs to be added to the cement in order to take care of the locally. So the second stage when you're doing, it has to be done after 6 months, not the usual 6 weeks or 3 months what we follow in bacterial infections. Number three, in when there is a failure of 2-stage surgery, either a fusion is indicated. That is the indication. There is no point in going and with again doing a secondary infection, because by that time the tissues are devoid of blood supply and there is local circulation is poor, so the chances of reinfection is extremely high. And especially in presence of a poor host, it may be diabetic, it may be on the immunosuppressants or old age. All these things are, the host is a poor host for a two-stage revision. So fusion is the option. And after a two-stage surgery, when there is a huge gap present, it is very difficult to fuse because there is no bone stock there around there. So there, what Nilen was showing that cam titan nail, that is a good option because that restores the space and restores the limb length. So in this particular case, if the infection is controlled locally, it is, see the tissues are good, then I would go ahead with doing a cam titan nail in this particular stage, which will restore the length of the limb and stability of the limb. Thank you.
Rajesh, Dr. Rajesh Gandhi, your experience with Eliza Rao. Are you there? Okay, Nilen, can you continue?
Yeah, thanks for those comments. So I have not used this, although I came across this. So Dr. Mohanty, have you used this or has anybody used this? So basically it's an uncemented stem.
Yeah, I have used it. And it's an extremely beautiful implant and very good stability you get with this implant, extremely rigid. You can just mobilize the patient next day. But problem is that there are chances of reinfection again. This titanium, so what they tell, titanium is protective of infection. So titanium, made of titanium, but if the patient is a poor host, suppose uncontrolled diabetic and all these things, then there are chances of reinfection. Dr. Mukhi knows about this. We have handled a case together that, in one of the patients which I operated and there is a reinfection after putting this cam titan nail also. So one has to weigh those things, host and the local tissue environment.
And this is fairly expensive. So I came across this other article also, which I'm just sharing for information, which is a cheaper option, where what they have done is they have put an external fixator rod inside both the medullary canal of the femur and the tibia and cemented them and just put external fixator blocks within the knee. So an external fixator as an internal fixator and adjusting it to around 10 to 15 degrees of flexion. And they have said that they've got good results with this also. Has anybody done this?
No.
It looks like a very innovative technique, but you just have to keep in mind that these external fixators rods are not designed for internal placement.
Right.
They have different metal qualities. So, you may be skirting a little bit of law and ethics in that area. But yes, it's an innovative and a different technique.
Yeah, so it is there.
Dr. Nilen, the problem, Dr. Nilen, the problem in our case is we don't have a good host cancellous bone. So proximally, we have cortical bone of the femur, and distally also, there is hardly very less cancellous bone for the fusion to occur. Almost it is cortex metaphysis, or probably it is in the diaphysis, where the area of the fusion is very less, as against if it would have been near the knee joint, you have a larger surface area of the cancellous bone. So that makes the fusion much easy. Here, it is cortex to cortex healing, which is very difficult in the disuse osteoporosis, and where, as Mohanty has pointed out, the host factors are not good. So it is all the more difficult.
So Sangeet, in these options, the knee is not going to fuse. The knee is going to work as a fusion because of the mechanical device, which is going to secure the knee in some degree of flexion and not allow any flexion. We are not looking for cancellous healing.
Just for our knowledge, can any one of you tell us the cost?
In England, we used to use a Mayday nail, which is a similar procedure. I don't know whether it's still available or not. It is called Mayday nail, which you put a stem in femur and tibia and articulate it at the knee joint. So if at all, we'll have to search whether it's still available or not.
The cost is 1,85,000.
Okay.
for this net. But one more thing I would suggest just before this, whenever you are putting a cement spacer, I put a cement dowel inside the intramedullary canal, both on the femoral side and the tibial side, especially when there is a stem extender is present. And then put a static spacer. Frankly speaking, one of my patients, Dr. Pachere knows about it. He has been infected since 2002, 15 years old infection, but rheumatoid lady. And there was suggestion for amputation for this lady from multiple places. I just put this dowels inside the femoral canal on the tibial side and put a very good static spacer. And she's walking still almost 2016 I have done. And it's almost 5-6 years now. She's walking around with a stiff knee, no recurrence of infection. We are lucky that you cannot tell that it's a recommended treatment, but at least the patient is walking around without any recurrence of infection and is not coming for any second stage.
That would have been bacterial infection, Mohanty sir, bacterial infection.
Yeah, bacterial infection. That was bacterial infection. Yeah.
Fungal with different ball.
Yeah. Fungal, poor host, poor bone quality, all these are against, all these things. But she was a rheumatoid lady with poor host also. Poor immunity, very osteoporotic bones.
Junjunwala, sir.
I have seen, good morning, for about 3 to 4 inches gap, like a giant cell tumor of the lower end of femur. Dr. Tarapurwala used to operate and put fibula, a long fibula, make it 2 and make vertical also 2 pieces. So there are 4 pieces of fibula, which he used to insert in the femur canal and fix up lower down and put a lot of cancellous graft, and that used to heal up. And that I have also done about 4 or 5 cases like that. And that gap can be filled up with a good fusion.
Bamboo hut technique, na?
Yeah, bamboo hut technique.
Yeah.
Bombay bamboo hut.
Tarapurwala's bamboo hut technique. Right.
So you used to tell Bombay bamboo hut.
Okay.
Bombay bamboo hut, yeah.
Has anybody removed this cam tightened prosthesis? Arthrodesis system? It is a disaster. You can get the whole femur out while removing this prosthesis. And or may fracture the tibia anywhere. It is a disaster.
The reason is the incorporation of the stem.
Yes. And I tell the patient beforehand, okay, it will be very difficult to remove this. And the bone is so osteoporotic. And I've done it in one case, which Dr. Monty also knows, was for amputation, but that lady is not willing. It was my case and had repeated infections. And we were working in collision. To remove this prosthesis is a nightmare.
Dr. Nilen, final comments?
Final comment is that we got to be really, really careful about infection. And I remember one thing when I had visited the Chanley Center at Wrightington. Roblewski was talking to a patient, and he was talking to a young patient. So he was saying that I will operate the first hip when you ask me to do it, but you will have to undergo revision when I say so. So we must tell all our patients that in case something is going wrong, we have the power to intervene early. So any infection has to be treated extremely early before they become these irreconstructible problems.
You have not told how will you manage that finally?
Well, I'm going to say, watch this space. I don't know what I'm going to do. I'm still in discussion with the patient.
Okay. Parag, can you conclude the case?
Yeah, no, very nice case. Huge amount of discussion. Good points by Dr. Mohanty as well, and really food for thought. It just tells you that joint replacements are not a easy surgery and has to be taken with a huge amount of seriousness. Thank you, Nilen. Very two interesting cases. I believe he has to leave now, so we'll crack on with the rest of the meeting. Thank you once again.
Thank you for accommodating me. Thank you. Bye-bye.
Bye.
Thank you, Nilen.
Thank you. Thank you.
Can we move to the case?
Yeah, so we are moving on with the rest of the order. I'll need to share screen now.
So you are presenting a case on ununited capitellum, right?
Yeah.
Okay. Those who are logged in via two devices, probably close one of them, because when you speak, there will be echoing from the other. Dr. Jhunjhunwala sir and Dr. Nicholas Antav have logged in from two devices. I request them to close one of them. Parag, unmute yourself. Yes.
One minute. Can you hear me?
Yes, yes. You're still sharing the screen.
1 minute. I'm trying to retrieve it.
Sangeet sir, there are some questions on YouTube chat. You want to take those?
Yeah, you can take. Can you put the question? I don't have access to YouTube right now. Agnivesh?
Yes, sir. There is a question from Dr. Satish Chandra Kale. It's basically a comment. We have forgotten the cost implication in vast majority of patients, and apart from clinical complications, the sinus drains the finances of the patients too. Fusion is the best.
Right. We agree to that. Parag, can you unshare your screen and again share it? That will be easy. Next question in the chat box.
Distraction. It's about the distraction osteogenesis by Dr. Murli Poduval. Distraction osteogenesis has advantages, but can need to be done over an intramedullary nail.
Stop share and again screen share.
But here we cannot use an intramedullary nail because there is already a hip screw and a plate proximally in the femur.
Right. And Dr. Kale has again shared his experience about that sometimes in repeat cultures after removal of primary implant in RA, patients, the joint fluid appears to be like pus, but it is sterile rheumatoid exudate. And he has experience with such a case recently.
Right. Parag, can you share it?
Yeah. Can you see me now?
Yeah.
And can you hear me?
Yeah.
Okay, so this is a slightly unusual but an interesting case. So ununited capitellum, not a common situation, but we do see it every now and then. So here's the case. So a 32-year-old gentleman, a young computer.
Can you press the enter button? Your cursor is on play. You just press the enter button.
Where is that? 1 minute.
Your cursor is already on play. Make it full screen.
How do I do that?
Just click the button, sir.
Where is that button?
Any button you click.
Okay. No, it's moving ahead.
It is not moving ahead. Can you
kindly click on the center of the screen once?
Yeah. It's moved ahead. No. Can you see the next slide?
No.
This is the first slide. Can you see this?
Yeah, but the slide is moving at your end, but it is not moving at our end.
So when you press the screen share button, please share the screen, not the presentation.
So go back to new share.
Yeah, just unshare the screen. I will do that for you.
Press stop share.
I have done that. So now please start the screen share again and select the desktop option.
Okay, so I pressed it. So now I've got all the windows open. So this is the one.
Either the first one will be the desktop or something. Whichever is the desktop, select that, please.
So yeah, so I've done that. Just press share again, correct?
Yeah.
Better?
Yes. Yes.
So you can see me now?
Yes, you are ahead. Now go ahead.
Okay, so this young man, a computer engineer, he fell while skiing and he injured his left elbow, which is a non-dominant elbow. And this happened in the United States way back in 2011. So at that time, he did have pain, crepitus, and he went and saw the... next slide.
Just press space or the next button. Just press space or the next button.
Yeah, can you... Yeah.
Yeah, go ahead.
So you'll have to bear with me. These are the x-rays and his scans, which I managed to get from this guy in the United States via his telephone records, etc., what he had. So essentially, he had a fracture of the elbow, which you can see here at the bottom right-hand slide. So he did have a capitellar injury, and he was seen at the local orthopedic surgeon there in New Jersey. So this was the imaging then, and he underwent a surgery in February 2011 in New Jersey in United States. So from the notes which he had, it said he had an internal fixation with headless screws, and that went uneventful, and he was put into a hinged brace, and he started gentle exercises from day 2. Now, unfortunately, from the 4th day, he started developing some pain and restricted movements, and he was unable to adhere to the protocol. So he then followed up with the primary surgeon a week after the procedure, and a x-ray was done. So this is the x-ray which he had, which he sent to me. So this was on 7th day post-op, 22nd of Feb 2011. So the operating surgeon had gone from back to front. He's put 2 headless screws, as we can all see, and he said he was happy with this, and he asked him to rest and take painkillers and then start physio again after that. So in spite of a week's rest, the pain continued, and he was not very happy moving the elbow. Nevertheless, sutures were removed. There was no infection from what I could gather. And he said the wound was clean, and he was advised another 2-week window in an above elbow slap, which he followed. And then he was still painful. So a CT scan was done at about 5 weeks post-op. And in spite of adequate rest, he was not happy. So this was the CT scan film at 5 weeks post-index surgery. So after this, he went back. What to do next is what we'll talk about. So he went back to the primary surgeon, and the surgeon said, look, he's not happy with what he's seeing, but he said, let's give it a shot further and try physiotherapy and see how you get on. So he continued physiotherapy for further 4 weeks, and really he was stuck. He wasn't really improving much. Pain continued, and he started hearing some noises as well. So the primary surgeon in the United States then said, look, let's undergo another surgery, and we'll try and fix the capitellum, which has lifted off. So he was scheduled for surgery in the first week of May 2011, but then he had to come back to India. And then first time I saw him in the month of May 2011, which was about 5 months post-index surgery, and he still had that persistent pain, stiffness, and dysfunction. So when I saw him for the first time, he had a well-healed scar on the lateral side. He had some tenderness over the capitellum, and he had 40 to 60, and he was stiff in supination. No neurovascular deficit, no overt signs of infection. Blood work was normal. And then the question is what to do now. So at this stage, after a lot of counseling, we said, look, let's go in and refix this. But I said, look, the shell looks very thin. You've had this surgery. So the x-ray on the left is the first one which I had taken at Bombay Hospital when I saw him for the very first time. So I said, we need to get the screws out and we'll attempt refixation. And the question in my mind at that stage was, what if the shell is so thin and starts crumbling when I take it off? Would he be a good candidate for capitellum excision? So, this was the dilemma in my mind. So after a lot of counseling, he was a computer techie, so he knew exactly what he was getting into. He had done all his literature searches and he was reasonably well informed. So at this stage, I'll just continue with what I did, Sangeet. So at this stage, we went on, and at the second surgery, which was on 8th of June 2011, I went in using the same old scar, which was a lateral incision, and I refixed it. I took out the old screws, I lifted off the cap, I put in some autogenous cancellous grafts on the undersurface, put the cap back on, and then I went in with headless Herbert kind of screws. And this time I went in front to back. He was fixed back to front. And then I put him into an above elbow slab for 3 weeks. And after that, I started gentle elbow range of motion exercises. So this was his X-ray post-operatively. I'd used the AO screws that time, headless screws, 2011. And this was at 7 weeks post-op when he came back, and he was flexing reasonably well, and the pain had come under control, and his crepitus, most important, which was consistent, had gone down. And then this was his image when he came in December 21. Showing me his range of motion and the heel scar. So that's his flexion extension, and this is his rotation. And I said, look, it was in this COVID era, and I said, get a quick X-ray so that I have a long-term follow-up as well. But unfortunately, he had to leave back, and I don't have his follow-up at this stage. So the question here is, which is the best approach? For redo capitellar fractures, for complex capitellar fractures, which is the best approach? So if you look at literature, several approaches have been described. Several hardwares have been used. So whether standard lateral, whether anterolateral, it seems that the anterolateral gives you the best exposure for these complex capitellar fractures, because you really can see the whole thing end on arm arch front to back. But mind you, you have a risk of a posterior intraosseous nerve palsy, which is almost to the tune of 15 to 20%. So your lateral approach is safe, but you're tinkering with the LUCL. Your anterolateral approach gives you the best exposure, but you run the risk of damaging the posterior intraosseous nerve. The implants which you have to use. So you've got cancellous screws, you've got cannulated screws, you've got headless screws, you've got AccuTrack type screws, you've got suture materials, you've got mattress sutures in a box configuration, K-wires, everything has been used. But if you look at the biomechanics, the headless compression screws are still the best. Looking at the stability and the fact that you can bury them without interference into the joint. The question is, how bad is excision? We should always excise radial heads and not worry too much. Can we excise capitellum? So I was doing some literature searches, and it's not as bad as what we thought. It's not all doom and gloom, and they don't run into early OA. Hotchkiss has got a nice series. It's a small number, but meaningful messages. So he said, if you can excise the fragment, and if your LUCL is intact, you will still have good functional outcomes. And by that, he says you'll get 15-20 degrees short of full extension to 135-140 flexion. And there are only 2 or 3 series, because capitellar fractures, which are highly comminuted, and redo surgeries are not a very common scenario. And that paper also says that you won't get instability if your MCL and LUCL are intact, which means when you start your capitellum surgery, do a good EUA first up and make sure that there's no collateral concomitant instability. So if you do this, you will be able to get away even with a capitellum excision, which we are not very familiar with. So thank you.
Parag, can you go back to the post-op X-ray?
Yeah.
And tell us, here. Now, your approach was a Kaplan's approach.
So, I used the same incision which he had, a bit like the Kaplan's.
And can you describe what was the picture intraoperatively, apart from what he has said? What was the extent of capitellar fracture? Could you type it?
Yeah.
Could you grade it, I mean?
Yeah. So, to be honest, I think this was one large, he had some degree of bone loss below the cap, but it was essentially...
No. Was it extending in the trochlea?
No.
Or not?
It wasn't.
It was a pure capitellum.
Yeah. So, type 1, Bernie Moray, with that McKeever classification, whichever you're following, but really type 1 is what I would have said.
Right. And what was the range before the surgery, range of elbow movement before the surgery?
So he was just 40 to 60, and he was, little blocked now in supination because that piece was blocking to some degree the rotations.
Okay. And intraoperatively, did you attempt release of the elbow or the anterior capsule?
No, to be honest, when I went in, I was not sure what I'm going to find. So once I felt that this was widely displaced, the capitellar, the articular edge was reasonably intact. And, it was just hollow within. I packed it. I didn't do any extra releases and I just fixed it again. And on table, I was pleasantly surprised. In fact, if you see all the serial x-rays, I was concerned whether the radial head was chronically subluxed and was not picked up because it was always lying low. But on table again, once I got the cap back on, the radial head alignment looked okay to me and I was quite happy.
Now here, your extension has also improved as well as the flexion. Flexion can be explained because of the exposure. Probably in the exposure, you release the anterior capsule and the anterior structures from the distal humerus. Right. Now, how do you explain the improvement in the extension where you did not do anything posteriorly?
I think it was pain inhibition, and therefore he was not able to extend totally from day one. When I saw him, even at the end of 2 weeks, I remember it's now 2011, but when I took him out, even for the suture removal, the first thing he said is, "Doctor, this feels different." And, he was an educated guy and he was quite receptive of the whole scenario. So I think it was just the simple anatomy restoration which made a difference to him. I didn't do anything particularly to get the extension. I didn't go down. I didn't do any extensive releases. I did not tinker with the coronoid in the front or with the olecranon fossa.
Parag Lad, Mukhi sir, I'll come to you. Parag Lad, unmute yourself.
Yes, sir. Dr. Mukhi, nice case. May I ask you a question? Do you think in your first slide, they have started mobilization within 2 days of surgery? Has this, because the post-op fixation even in US was not very bad, but do you think early mobilization has moved this fracture? What could be the reason for this failure?
So, now the debate is, when you have a type 1 capitellar fracture, are you happy with 2 headless screws or do you need 3 or 4 headless screws? So if you look at literature, in the past, we always thought 2 were adequate. But now there's more data to support that it's a globe. And if you want adequate fixation, you need a tripod kind of a fixation. What you do, perhaps for a radial head fixation as well, because the circumference has got a large surface area. So, he was done at an upper limb unit in New Jersey. So I'm sure the guy knew what he was doing. So at that stage, I think 2 screws, perhaps he must have thought was adequate. He went back to front. Now, this is where the debate is. Should he be going back to front or front to back? I think on day 1, he should have gone front to back with headless screws if he was using this.
Parag, just because it is done in New Jersey, that doesn't mean it comes with a stamp that it is the best. If you go back, can you go back to the first X-ray? Probably the trajectory of the screw for fixing the capitellum was not adequate, or probably the exposure. These are the 2 commonest reasons why
this failed.
This failed. And if you see here, you have the first X-ray, the pre-op X-ray. Probably.
One more thing I want to say: when you screw from back to front, there's a distraction force. Exactly. Always in life, screw from front to back.
Parag, can you go back to the first X-ray, injury X-ray, if you have? Now, if you follow that, probably it is going in the trochlea. We don't have adequate pictures. Okay, the lateral view, if you can see a double arc here.
Yeah, but if you just go to the CT here, so, when I took him up for revision, that was my concern. How much of the articular cartilage is involved?
No. The CT is not representative. And if you see the AP view, you can very clearly see the extent of the, of the fracture on the trochlea. So probably it has crossed that ridge. And that may be the reason. And both the screws are on the lateral side. Can you go back to the next X-ray? Post-op X-ray, So here, AP.
No, this is what he had said. Post-op on day 7.
There is one more AP view.
This is the CT which they did at 5 weeks.
So here, if you see, probably both the screws are on the lateral side. So that may be one of the reasons. The fixation was not adequate, and that is why it gave way. Second was the trajectory of screws. And third is the inadequate exposure. These are the three commonest causes of failure. I want to ask Rujuta, in a pediatric age group, can we excise, Rujuta, can we excise that capitellum if it is just a flake or a type 1 or type 2?
Yeah, so if it's causing intra-articular issues, then yes. But otherwise, it gets classified as a trash lesion, and then you open and try to reduce it. But if it's become already redundant and avascular, there are caveats. But I mean, ultimately, you have to do it. You have to warn them of the future elbow instability, and it may just become a stiff elbow. But if it's really, even if you gain 30 degrees of motion, an old unhealed capitellum with caveats. I mean, it's not the best scenario, best choice, but okay. I mean, if you have no choice, what can you do?
Dr. Mukhi, sir, you want to comment?
Yeah, this is a day one failure from New Jersey only. They should reduce that capitellum inside the joint. The capitellum remains outside. And the screw has to be from the capitellum anterior to posterior. You cannot get a fixation from back to front. You pass the K-wire from back to front, but pass the screw from the front to back. That is the trick.
Right. So thank you very much. Can we close the case, Parag?
Yes, yes. Yeah, we'll move on. We're a little behind time. Yeah.
Unshare your screen.
Yeah.
The next presenter.
So we've got Dr. Girish coming up next. Girish, are you ready?
Yeah. GD, unmute yourself. Can you share your screen? Yes.
Yeah, can you see it?
Yes. Enlarge it.
Better?
No. Again, the same problem like him. Press on the center of the slide.
Oh.
In the meantime,
Girish sir, you'll have to unshare and then share the desktop, not the presentation.
In the
Okay,
meantime,
just hang on.
Yes.
In
Yeah,
pediatric cases, don't excise it, because with growth, you will get the wrist problems and drudge problems. So you must always take out an X-ray of the lower end of the radius and the wrist before you touch the capitellum.
Even Parag has mentioned, in a primary case, you are not supposed to excise it. The reason is it is not only capitellar injury. It is always associated with avulsion of the common extensor and the lateral collateral ligament.
Yes.
So that makes the elbow unstable, and hence primarily.
Sorry guys, can you see this now?
Yeah.
Can you see this now, Sangeet, in the
Yes,
slide
yes,
show?
go ahead. Go ahead.
Okay, now this is a comparatively shorter case considering what we've just discussed. So this is a patient with this is a gentleman who's currently aged 57, known case of ankylosing spondylitis with predominant hip involvement bilaterally. He was operated at our institute, the Bombay Hospital, in 1989 by the late Dr. C.G. Pradhan, and he underwent a cemented bilateral total hip replacement. They were both done a week apart. He presented to me in 2011, that is 22 years post-operative, with pain in the left total hip replacement that was done for him. And he had tried some analgesia by his local family physician with no results. So this was what his X-ray was on presentation. So what I want to highlight here is that in the current scenario where we run down cemented implants as something which are to be in the archives, this is somebody who at the age of 25 had a surgery and which lasted him very well for 22 years before he presented with one pain on one of his hip replacements. The left was the painful one. The right, he was completely asymptomatic and functioning pretty well. So as you can see here, there is extensive destruction and osteolysis of the acetabulum, but the femoral stem remarkably looks good, though it is cemented. So another lesson for all of us who vouch for the uncemented expensive implants. So this is a little further views showing us what the the cemented left side looked like. And another thing, sorry. This is, okay, hang on, sorry, I'm rushing. Yeah, so another thing which I wanted to point out here was, for some reason, there were no cement restrictors used when this surgery was done. So there was a huge column of cement beyond the tip of the femoral stem as well. So I'm going along with what I did for this patient. This is 10 years ago. So I had to do a Birch Schneider cage using a cemented cup on the acetabular side with a lot of bone graft from our local bone bank at the hospital. And on the femoral side, I did do an ETO till the tip of the stem as it is advised, and hoping that the cement below it would come out easily. But to my surprise, that was not the case. And I had to extend the ETO window further down and landed up using a longer Wagner's type of stem for the reconstruction. So there was a long ETO there. There was a lot of bone graft on the acetabular side with a cage to support the bone graft and a cemented cup. Now, look at this X-ray 6 months. He was doing well on the left side and was completely asymptomatic. The right side still looked very ominous on the X-rays. I tried my level best to convince him to get the right side done, because it was going to only get worse as the osteolysis and the bone destruction continued. But Indian patients, being Indian patients, said, "Dukta nahi hai, nahi karayega. Jab dukhega tab dekhega." So that's exactly how he continued for the next few years. 2 years post-op, you can see his gait. He was comfortable back at work with no major problems. And this, at 8 years, the right sides looked a bit worse than what it looked initially at the first 2-year post-op stage. And finally, at 10 years post-op, he presented saying, now the right side is painful and I would like something done for it. And if you have been paying attention to the acetabular lysis on the right side, it has progressively worsened on the right, and life would have been a little easier for me if he had accepted surgery earlier. But he is now 32 years post right total hip replacement cemented, and the cemented stem still looks good. But obviously we'd have to take it out, because being a non-modular stem, it would not really be something which we could work with in the revision scenario. As far as the acetabulum was concerned, I did do a CT scan, but that CT scan was a bit misleading, did not show the extent of bone damage that was there, which I found on table, which I'll just come to in a minute. I had to keep everything ready for the reconstruction, and this is what we did. This time I did an anterolateral hard hinge approach and did the anterior based ETO rather than the posterior approach, and found that there was no bone on the acetabulum to take any sort of uncemented jumbo cup or any augments either. It was just completely like the pelvis was not supportive for anything. So I had to go back to the same cage construct that I did earlier. And this time on the femoral side, I opted for a reef stem, which would give me additional stability with distal fixation. And so this is what he looked like at the end of this is now, he is now 6 months post-operative. This is his post-operative X-ray. You can see the ETO as well aligned, and The acetabular reconstruction is looking good with the bone graft, etc. Considering from where we started off. These are his X-rays now at the 6-monthly stage. And he's got a good, adequate SLR and good hip range of movement there. And he's walking well 6 months post-operative, though his muscle rehab still needs to be progressive. Now, the reason I'm presenting this case is that we are doing a huge number of hips for various pathologies in young patients. Now, this patient had a long-term survival of cemented implants, as I said, 22 and 32 years. Now, his only question to me is, sir, how much am I going to be lasting with the new implants that you have put in? So can any of the experts on the panel enlighten me on how long do we expect these implants to last? Remember, the left side is now 10 years post-operative. The right side is still new. It's just 6 months. And what do we expect? What do I tell him onto that question? He is only 57. So what does the future hold? And in my humble opinion, this is the acetabular revision, which is the final frontier in revision hip surgery. So I look forward to views from seniors, Dr. Mukhi, Dr. Mohanty, and any other gentleman who can please enlighten as to what better or what different I could have done with the amount of bone destruction and lysis I had. Yes, sir. Mukhi, sir.
Yeah, my request is that the stem which was put by Dr. C.G. Pradhan was donated to Bombay Hospital by Dr. Ranawat. It was a titanium stem which was discarded in US. It is a day one failure. But luckily, being an ankylosing spondylitis, where the range of movement is very less and patients' expectations are minimum, he has survived that. But don't use titanium bearing stems at all. They are discarded from US, they are thrown away, and I have many of them donated. And
so that was the isoelastic stem. This is the Thackeray stem. This was this is not an ice. This is not. This is a copy of the Charnley, but of course non-modular.
Titanium bearing.
But how do you explain a 32-year follow-up of the same, sir?
Yeah, that's what I'm saying. He's lucky.
Lucky. Okay, fine.
Yeah.
So can he be? Will he be lucky? Will he be lucky with the new stems that I have used, sir?
Yeah, only the bearing. I'm not accepting the bearing. You have used metal to poly.
Dr.
You
Mukhi.
used metal to poly. I would have used ceramic to poly.
Yes, there was some issues of cost constraint.
Dr. Junjunwala wants to speak. Dr. Girish, Dr. Junjunwala wants to put a word.
Sure,
yeah.
Junjunwala, sir.
Yeah. So this stem, which is given by Ranawat, we have used at least 2,000.
Wow.
And the survival rate of the stem is more than 20 years in all the cases. So it is not a question of titanium, which is failure.
Titanium bearing is not used with
Girish,
yes, sir.
If I understand, the inferior flange of the Schneider cage has to go inside the ischium, right? Let me complete. Hold on. Or at least have a support of the bone. Okay. So on left side, the follow-up which you have of 10 years, probably it is holding on the ischium somewhere. Same is not happened on the right side. And as a result, if you see, all the fixation is at the superior part. Okay. And as a result, the cup has already started loosening. You can see the zone 3 of the cup, the inferior part of the cup, the interface between the cement and the inferior part of the acetabulum. You can see a clear lysis going right up to the center of the cup, going inferiorly to the ischium. So here, probably the placement of the Schneider ring should have been improved by what you have done exactly on the other side.
So that was what I wanted to highlight.
Dr. Mohanty.
If you had accepted
Yeah, let
On to
me
your
first,
comment.
first thing, Girish has done an excellent job within this difficult situation. And as you rightly told, as Sangeet rightly told that, the inferior flange of this cup has to be fixed either a couple of screws or it has to be fixed in the bone itself. The flange has to go inside the bone, like you do a blade plate, that it has to go inside. So there should be some kind of fixation inferiorly, some hold inferiorly. And the cement which is there medially, the cement probably from the cup, it has gone through the holes and going medially. There should have been some bone grafts. Above that, the Brook-Schneider cup is fixed. Brook-Schneider for never cement is put on the medial side of the Brook-Schneider cup. The cement has percolated from the cemented liner through the holes and it has gone medially. That's why it is looking like this. It is not a primary fixation modality. But next, coming to the hip number 2, second point is that these are triad hips. The name was triad hips. It was manufactured by Johnson Johnson. Dr. Mukhi rightly told this was given by Dr. Ranawat to Bombay Hospital, and many of these hips have done really extremely well. Like in this hip, it has sustained almost 22 years or 32 years. And number 3 point is that suppose in a case in an old patient, when the femoral stem looks well fixed, like in this particular case, with maybe if you want to go quick in, quick out, nowadays there is an option of this dual mobility cups. So you can keep the stem intact and just assemble a dual mobility, polyethylene liner on this head and just change the cup and you can get away with that. But of course, the soft tissue balancing, you have to take care if it is possible. Then this is one of the options which is available. There is no literature available on this, but this is some of the cases, we are hearing people have done. I have not personally, I have not done, but this is one of the options one should keep standby to go quick in, quick out when the stem is very well fixed and cement bone interface is good. Next point is that if you want to tell this patient about prognosis in revisions, we never tell about the prognosis. Frankly speaking, primarily you tell, okay, 15 to 20 years, it may last. But in revision, if I tell my patient, particularly if it goes 5 years, then if the outcome is very good. It varies from patient to patient, the fixation, the bone quality. There are so many factors involved in revision surgeries. Even compared to left, right hip, you cannot tell that, left hip has really done very well that 10 years, but right hip will go 10 years. You cannot guarantee that as well. So we always tell if in 5 years it goes, it's fine. And if it has gone 10 years, so I cannot guarantee it, but we'll see time and tell. That is what you have to go into tell.
Girish, anything more you want to add?
Yeah, I wanted to ask if by chance this fails in say 3, 4, 5 years, what option do I give him? Because he doesn't have any.
Trabecular cup. Trabecular liner of Zimmer.
So there is no bone stock to take any. I had a trabecular augments available. There was nothing to hold them on, sir.
No, they have it. They have it, and but, this Bird-Schneider cage has become outdated.
Yeah, you have fixed the Bird-Schneider cage, Girish. You have fixed the Bird-Schneider cage with couple of screws there. So augments could have been
with the trabecular cup with the ceramic liner.
Dr. Jhunjhunwala, sir.
Yes.
Sir, you are seeing a lot of these cases which have been operated by Dr. Dholakia, sir. And we all are aware that the delay gives more significant bone loss, and that makes the longevity of the revision poor. The cost increases. But how do you convince the patient, those who come for follow-up at say 20 years, 25 years, 30 years, like in GD's Dr. Girish case, here he had the same problem. The host or the bone stock became poorer and poorer as he refused surgery because he was asymptomatic. How do you address that issue?
I feel all these stems are working very well and they last for another 10 to 15 years. Regarding acetabulum, you have to do revision of the acetabulum in such a way that the reduction is perfect. And now whatever is done with a cage is fine, but inferiorly the hook of the cage usually goes in the ischial tuberosity, which has not gone here, and therefore it may not last longer. As already I have shown that there is a cleavage coming up between the cement, between the cage and the bone.
Thank you, sir. Dr. Parag, can you sum up the case?
Girish, thank you. Very nice case, good follow-up. So for our occasional THR surgeons, I will share my one experience when I worked in UK with David Lightower. So he used to do a young adult hip clinic, and he would do cemented hips for all the young patients. And regularly in his OPD, I would see 20 to 25-year-old follow-ups those days. And that was first and second generation cementing techniques. And he would always say cemented hips are very good even in young people. So going back to what we are saying, cementing is an art. And if you can master it, cemented hips again in young people is a good option, as long as you know what you're doing. As long as coming back to the longevity of the second one, Girish, I think you should tell him 5 years, and anything more than that is a bonus. The problem is once that wears out, you are in a real soup. These trabecular augments, etc., may or may not hold even after that because your shell looks very thin.
There was no way they would hold when I did the second side 6 months ago. There was just no bone.
Yeah,
and that's exactly my question. 10 years he waited on that and the bone just melted away. And we don't have any way of convincing, except if you use Nilen Shah's statement, which Wroblewski told his patient, you buy your primary hip, I decide when you do your revision. I hope our patients understand that. That's the wishful thinking.
Thank you very much. We close the discussion. We move to the next case. Dr. Kulkarni, can you share your screen? Your audio, you have muted yourself. Unmute yourself, Arvind.
Yeah, can you see me?
Yes.
Can you see my presentation? Yeah.
Yeah.
So good morning. Just to shake up and remind that orthopedics is not just capitellum and joints. Spine is an integral part of spine. So I'll start with this very interesting case. Just like the Queen of Hearts who just passed away, and the England Queen who's marks 70 years of ascending to throne today, mine is a female patient, a garden variety case. Patient has lower limb pain of 2 months duration, progressively increasing in magnitude, associated with paresthesia. Typical presentation aggravated with flexion, relieved with lying down. Normal neurology, a right-sided SLR of 30 and a crossed SLR of 70 degrees. Rest of the examination is absolutely normal. So this is nothing offbeat about the presentation. The dynamic and static X-rays are unremarkable. There is no instability, etc. So what is offbeat is the side of disc herniation. If you can see, so the pain is on the right side, the herniation is on the left side. And this was a shocker because then you don't know what to do next. So these are the dilemmas, and each and every question is interrelated to the other. But at the heart of it lies, the bottom line. The patient asks you, "I want to be, relieved of this particular pain." So can I just stop here? And I would like the seniors, elders, colleague, Vishal, etc., to share their experience if they had something like this. If they've seen something like this before. So what would be the diagnosis, which again explains the symptoms, and then which will direct the treatment. And in case you operate, you do go on both sides or one side, and would we at the end, as I said, the bottom line, would she benefit from surgery?
Dr. Antav, please. Dr. Nicholas Antav. Unmute yourself. He is not there. Dr. Mukhi.
Yeah, you give a block, no, epidural block on the right side, and you block that now. And
Okay, so
see,
But sir,
that's
how
been
do
done.
you?
yeah,
Yeah,
that
yeah.
will be the test.
No, she failed root
And-
block. It was done on both sides, Dr. Mukhi. I put
No,
it
no,
here on the
to test
side.
that it is a disc which is giving the opposite side pain. This is known entity. Some percentage of cases will show you and present with opposite leg pain. It is a known entity.
Okay, so
And you have to tackle the pathology.
so you've seen such cases before, Dr. Mukhi?
Yes, I have
Okay.
seen 2-3 cases as I remember.
Mhm.
And in the literature also says.
Arvind,
Yeah.
You must have scanned the MRI and visualized it properly.
Yes, yes.
So how was the root on the right side at the disc level, at the cut, at that cut?
So if you see here, so the root on the right side is absolutely free.
Okay, okay. So that ensures the pathology is not the root, which is a cause for the right-sided pain.
Yeah.
And
so
your root block has not given a positive test.
So she had undergone this root block by a pain management specialist prior to when she came and presented to me.
You remove this disc and she will be all right.
No, sir, but to advise a surgery without confirming the cause of pain, how can you go ahead?
Doctor, what was your conviction to go ahead with this kind of surgery?
Yeah, there is the literature. There are case reports.
So I'll go ahead. I agree with Dr. Mukhi. So we did a tubular discectomy, and this was the fragment that came out, and she was absolutely relieved of her symptoms. So what was comforting to us was the previous experience. Though many of us would have not seen such cases in our practice, there is enough literature to comfort us, and each author has his own theory to establish the pathology. Without any substantiative argument. So one says it would be because of stenosis on the opposite side. One connects it to this particular phenomena which neurosurgeons are talk about, that is Carnohan-Workman notch phenomena. It's a paradoxical neurological manifestation where the motor deficit is on the same side as the primary brain injury. So, but again, this is speculation. So what has gained traction in the last recent few papers is about traction. So there is significant consensus of this particular theory saying that when the apex of the herniation is in the center, close to the center, there is equal amount of traction on both sides, on the both roots. But if it is on one particular side, if it is deviated to the contralateral side, sorry, the ipsilateral side of the herniation, so there is more traction on the opposite side. Again, this looks quite speculative, but this is something which has gained some consensus. And again, so why does it happen every time? So the other is vascular theory, that it is similar to compartment syndrome, where either there is venous congestion or there is impairment of blood flow to that particular root that causes these contralateral symptoms. So this is definitely an unusual presentation, creates a lot of confusion in the doctors and team's mind. However, there is previous literature to comfort us, but it's very important that you counsel the patient about this particular entity, which is a bit paradoxical. So while there is significant literature to comfort us that such an entity exists, there is no consensus of the cause. So we need to do basic research studies to establish the cause.
Nice. Excellent.
Arvind, that in the presence where your symptoms are not correlating with the investigation, how will you convince the patient? And if this fails, how do you address that issue after the surgery?
So you get the patient's relatives down to a chamber or in front of the patient, and you just tell them that this is something which is not uncommon. This has happened before, and this is something that is not matching. And apart from that, we have no other direction to proceed.
Vishal?
Yes, sir.
Are you there? Yeah.
Yes, sir.
Your comment?
Very tricky, sir. I mean, in my practice, I mean, this requires a fair amount of conviction to really believe that the symptoms may be coming from there. And in such an August meeting where we are sitting here, I think sending this message can open a Pandora's box to discuss it on a wide platform, that if there is no clinico-radiological correlation, then to justify a surgery is like a trial of treatment, which I think medico-legally it may be a little a challenge if the patient has any which ways. Even in patients where we have good clinico-radiological correlation, some amount of back pain, some amount of leg pain still persists post-operatively. In fact, 20% of our patients will keep coming back and saying paresthesia reh gaya hai, thoda pain idhar dukh raha hai, thoda udhar dukh raha hai. So if such patients post-operatively they come and say about the same thing, ki abhi bhi thoda pain dukh raha hai, then what? I mean, tomorrow if this patient takes it to the court of law and just कि साहब मेरा pain right था, आपने disc left की निकाली है और मेरा pain right का अभी भी बाकी है. Have you did a trial of treatment? Then we may be in a soup. I mean, as a assumptive treatment, yes. Till the time we have really communicated our concerns to the patient fairly well, and it's a informed decision making, like Arvind pointed out, that you have spoken to the patient everything clearly. And you have mentioned it that this treatment of doing a endoscopic or microendoscopic discectomy may be a speculative, assumptive treatment based on my conviction. Whether you want to be a part of it or not is it. So I would not treat this like a blanket thing for all patients with contralateral disc and ipsilateral pain to go at surgery.
To both of you, any dynamic study can help us.
Sir, I am a firm believer that dynamic studies are meant only to rule out instability, mechanical symptoms. Any neurological symptoms should not. If it is not present on rest MRI, it is not seen on dynamic MRI. And if something is seen only on dynamic MRI, I would not treat it surgically.
Arvind, in the review of literature, all the cases mentioned had a similar size of large disc. That means this phenomena is seen only in the large disc contralateral side.
So a few, the articles which are coming in prominent journals like European Spine Journal, etc., show a similar MRI picture. So with the base on one side, in the center, and apex tilting towards the opposite side. So that is a theory which is put forth to substantiate traction as a cause of this kind of a situation.
So I think cross SLR as a sign. It was elicited based on the same, that a large disc producing symptoms on one leg and having a cross SLR positive on the other side mentions that traction on the other nerve root can be a cause. However, like I again say, it requires a fair amount of conviction and belief to believe that these symptoms with no compression on that same side are caused by a disc on the other side. And that conviction again cannot be a treatment unless you have convinced, spoken to your patient in great detail and have involved him into informed decision making, because it may easily fail. I mean, your patient's symptoms may be just coming from something. It can be from piriformis, it can be from a hamstring stretch, it can be from an iliotibial band, it can be from anything but not from the disc. So, this speculative treatment can prove to be an experimental surgical treatment, and you may be in a big medico-legal soup unless you have really involved the patient in decision making and you have shared your conviction about the cause of symptoms. Arvind, I hope you also agree on this.
Yeah, that's what, so this particular case, there are few things. One is, I told them that unless they drive me to surgery, I wouldn't operate. And I had a fair amount of counseling with this patient. I would, as Vishal highlighted, I didn't want to, be put in a corner if she did not get relieved of symptoms. So what was relieving here was there were close to 25 cases which were reported in literature, which I could explain to the patient. Second is, along with pain, there was some degree of paresthesia, which hinted towards a neurological symptom rather than any other non-spinal symptoms, like, coming from SI joint, hip joint, knee joint, etc. Third is, it was L5 dermatomal. So when you have pain coming from the knee joint, SI joint, etc., hip, so usually it's S1, it goes posteriorly along the hamstrings and along the hamstrings and the gastrosoleus. So L5 dermatomal, I would be more in favor of root pain rather than
I would, yeah, I would,
Yeah.
I mean,
Hetal,
try everything to avoid surgery in this case.
Vishal, hold on. Hetal has raised a
I
voice.
just wanted to ask, doing a nerve root block, can it act as a diagnostic test whether the surgery will work? So if the nerve root block works for time being, then you know that
So,
probably
this patient had undergone a root block with no relief on both sides.
Yeah, on both sides.
Harshad.
Vishal
Harshad,
said,
you have raised.
yeah, what Vishal said, I think we'll have to keep in mind. For a large disc, like in this case, you can be fairly certain that that is causing traction on the other side and causing symptoms. But similar, if you translate it to a smaller disc, you may not be able to reach that conclusion. And if you are really convinced that the one side disc is causing an opposite side symptoms, here in these cases, probably a minimally invasive surgery is not the right choice. You should try and see the roots on both sides and decompress both sides so that you're sure that you're giving the result which the patient really wants.
So Harshad, there is this paper in European Spine Journal where they had a similar situation, 5 cases, and they went only from the ipsilateral side. Only from the ipsilateral side. They did not even tinker on the opposite side.
Yeah, but you really require to be convinced that that is the one which is causing the symptoms. In a large disc, I understand, but where the disc is borderline or you're not having yourself sure whether that disc is causing symptoms on the opposite side, I think it's wiser not to operate. And if you have to operate, better to go for open.
No, so this was done with proper counseling. That's what I want to highlight.
I'm not talking about this case, Arvind. It's just a general statement.
Vishal, my question is, would you explore the opposite side? It would take only 5 to 10 minutes for you to have a look on the opposite root, which was symptomatic.
So 2 things. I mean, before I answer this question, which is very, very interesting. First thing, what Hetal and Harshad mentioned, to me, failure of conservative treatment is not an indication. In my books, it has to be an excellent clinico-radiological correlation. In my books, I would say any kind of, unless I am extremely convinced, which I have not done till date, I don't think I have done any such case. And even root blocks are only therapeutic. This notion कि root block दिया और काम नहीं किया तो surgery करना चाहिए, या root block ने काम किया, that means it is the compressive side इसलिए surgery करना चाहिए. Both are wrong methods. Root blocks should not be treated as an indication for surgery. Whether it works or it doesn't work, that's a wrong way to do it. And because there are so many subjective factors into root block, it is just one therapeutic method. If it doesn't work, it doesn't lead to a door opening for a surgical treatment. Or if it works, still it doesn't open the door for a surgical treatment. Coming to your question, sir, that if a patient doesn't have symptoms on one side and a disc is still seen on the other side, I would surely not explore it. A radiological compression which is not producing a clinical...
No, Vishal, you have not understood my question. Having, like as Arvind has done, having completed the disc surgery, removing that large fragment, excluded disc, and now he wants to be sure, or he wants to have a look on the other side, on the other root, which is symptomatic. So would you put your scope, or would you go on the other side as well before you close?
I'm answering the same thing, sir, that if the symptoms are on the left side, I have explored from the left side. If there are no symptoms on the right side, I would not touch the right side. Because by an attempt to do a right-sided exploration or visualization, I may end up creating paresthesia, post-operative arachnoiditis, or fibrosis on the opposite side, which can produce even if it is the slightest paresthesia, there will be no answer from my side to tell. And this era of complete minimal invasive surgery, if the symptoms are on the left side, just do left, come out. If the symptoms are bilateral, do both sides. Even in the past, if patient has a history of right-sided symptoms, ki pehle tha, abhi nahi hai, even in those cases, I will do it. But if patient has no symptoms on the right side today or in the past, I would not explore, not visualize, not see. Even if it is just 1 minute extra surgery, I will not do it. I will not have no explanation to paresthesia, post-operative developing on a side which patient had absolutely asymptomatic side. So I would not do it.
Dr. Jhunjhunwala, sir.
If there are symptoms on the opposite side.
Sir, your 2 devices are working at present. Close one of them.
Particular case, Dr. Arvind said that SLR was restricted on the opposite side also. So I will explore on other side also and see that root and disc. And as most of the people said, they will open it on the opposite side. As Vishal said, if there are symptoms, he will open it on the other side also.
Shubhranshu, quick comment.
No, just sorry for my ignorance. Whether EMG NCV will help preoperatively? I'm just asking Arvind and Vishal.
I don't think that helps in the case of radiculopathy.
And number two, if the pain specialist has given the block, would you prefer to give a block yourself and check whether he has given the block properly?
So when we had this counseling, this went on for 2 or 3 days to come to a decision to operate. So this was also discussed about, but ultimately, they are not ready for something short of a radical improvement, again, which was not promised to the patient. So in a situation like this, what do we depend on? We depend on previous literature, and there was abounding literature to support this. So that is what saved the skin.
A quick question.
Wake up
earlier,
test. Wake up test. Once you remove this disc, you ask the patient, is your pain on the opposite side disappeared?
I don't think that is 100%,
yes.
Sir.
Yeah, the patient says, yes, I'm totally relieved immediately.
Sir, all patients of residual disc, recurrent disc, for 6 to 7 hours post-surgery, they'll have no pain. Only when you go for rounds late in the night or the next day morning, the pain shows up. So,
Arvind, not in this case. Earlier, maybe 2 decades back, we used to do that saline acceptance test, where to reproduce the pain before the nerve blocks, like injecting saline in the disc, and then if the patient reproduces the pain, is
like
able to
discogram.
reproduce the pain. Yes, the same thing. So here the disc was extruded, so there is no role of that.
Yeah, possibly.
So is there any role of in a contained disc?
Yeah, so this is something which is not done commonly. A discogram probably would have helped.
So, but nowadays provocative tests are not done. They are just not done because you're creating a portal by which infection can occur and all that. So you don't do any provocative tests nowadays.
So excellent case, Arvind. Good discussion. Parag?
Yeah. So thank you, Arvind. One last word. It just comes down to a watertight consent and how you counsel patients. Spine surgery is a big game play. So we have to be really careful before we take patients on. Sangeet, we need to quickly speed on. We are a little behind time. We've got HRJ sir coming up next. HRJ sir, are you ready? You're muted.
It is a, can I?
Yes, sir. Go ahead.
This is a very simple technique for revision of the cup. Mr. Rajaram Kori, 52 years, male, underwent Austin-Moore prosthesis in Madhya Pradesh in 1994 for fracture neck femur. Austin-Moore failed in 4 years. He started getting pain, and then he came to Bombay, where a cemented total hip replacement was done in 1998. Next. In 5 years, this cemented hip got loose. You can see in the X-ray, it is absolutely stem is loose. A revision uncemented long stem with uncemented socket total hip replacement was done in 2003. And there was uneventful recovery till August 20, that is about 17 years. After 17 years, he came again to Bombay, saying that he is getting pain while getting up from the chair or while walking, he gets pain. But if he does rest, there is no pain. And his blood tests were normal. Radiologically, cup and stem both looked stable. You can see here it looks stable, except little osteolytic area in the proximal part of the femur. but distal part is well fixed and stable. On clinical examination, patient had pain on active movements of the hip. Next. So as he was complaining of pain, and I could not find any particular reason, I still opened up the hip joint, and I found the poly was found to be worn out with a fracture in the posterolateral region. Stem was found to be stable with good distal hold in spite of proximal lugency. On table, frozen section did not show any infection. So now the shell was very good, stem was very good. Patient did not want to spend money for all these chains. So what I did, I kept the shell stable as it is. It was a multiple hole shell, and I put a elite cemented cup of Dupi in the shell itself with the cement. And next. And after 5 days, the patient could walk without pain. He could sit and stand without pain. And this is the post-op X-ray. You can see it is well stable. Shell is well fixed. The poly is inside the shell, and it is doing well. The cup shell was 54, and I put 47 millimeter poly, cemented poly inside that cup, and it fitted well. And my soft tissue tension was also perfect. So he did well. So it is now 1.5 years, he has no pain. And literature, we got only one article, cementation of a dual mobility cup into a well-fixed cementless shell in patients with high risk of dislocation undergoing revision totally orthoplastic. Thank you. वो दिखा इसके पहले का Yes, any comment?
I would have used a ceramic liner and dual mobility.
Yeah, dual mobility would have been better for the
with ceramic liner.
Also. But I could get with this a proper soft tissue tension.
But with this cup, is dual mobility option is available because cup has to be left intact. Then you have to put some liner inside for that for a dual mobility. So that option should be available with the company first.
No, most of the companies they change their liner and then it doesn't fit in the previous shape.
Metal.
No, sir. Means what I am asking, for this Esculap, I think you had put Esculap cup. But
no,
for
putting I have put Dupi's cup.
No. The original cup was a Esculap cup, correct?
Eye contact.
Not difficult.
By contact cup was there. So with the by contact cup, whether there is a dual mobility option available with the Esculap, then you could have put a liner which is fitting into the cup, metallic liner which is fitting into the cup, then only you could have put on the dual mobility on this side. So here it is difficult to put a dual mobility unless that metallic liner is available with that for that particular by contact cup.
And if you don't have it, you put at least a ceramic head. What's wrong in that?
Yeah, ceramic head you could have put.
Yeah.
Ceramic head where? In the shell?
No, the poly.
But how to fix up the poly?
Cement the poly in that cup. You have done the best job.
It is same thing as what I have done is same thing.
Same thing, but you have used a metal head again. Why didn't you use a ceramic head?
So the cost constraint was there, sir. Cost constraint.
Now patient was very poor.
One cup of tea.
Few
Ceramic
thousand
head
rupees.
cost 1 cup of tea for 20 years is equivalent cost. Just
So
tell
that
him
is
to
okay. Regarding the SIRS procedure, that changing exchange of the polyethylene only and putting a cemented polyethylene liner is a described procedure, especially in old patients in the literature. What you have to do, you have to do little burring of the inner surface of the cup with a burr. So make it rough. Take a metallic burr and make it rough. Then do the cementing of the polyethylene. It's a
See,
described procedure.
See, this shell had multiple holes.
Yeah.
So that was giving a fixation with the cement.
So can you go on the
Right.
first slide?
You have used
You have used a runabout stem earlier to this.
This is not
Earlier
runabout
to
stem.
this.
This is
Earlier to this.
this one.
This is the same titanium runabout donated stem.
Trad
which is
stem.
discarded
That
in
one.
US.
Go. Okay, yes. But it is, I will say it is 2 or 3% stems are causing like this loosening.
Yeah, it has just
Otherwise,
lasted 5 years.
97%.
It has just lasted 5 years and the
perfect.
lysis is
Yeah, after
similar.
5 years. I have
5
30
years.
years follow-up also.
And the message should go to the delegates that this is a very good option, that when the cup is very well fixed, then one can take out the liner and cement just a liner in.
Yeah, just
that is the message from this. Yeah, with
cemented liner.
Yeah, quick in, quick out procedure,
Yeah.
and it is quite helpful.
Yeah,
It
that
has
is
got
what I have done.
Yeah, yes, sir.
Okay.
Can move on to next case, Parag.
So thank you, sir. We've got next case coming up. Dr. Atul Bhaskar, are you there?
Yes, Parag.
Yeah. Okay, Atul.
Let me share my screen. So I'm going to present a case of Monteggia fracture, and this is what we see commonly in practice is children presenting with this kind of injury where the diagnosis of radial head dislocation is completely missed. And we've got a series of these cases like this child, the one more child presented here with the Monteggia fracture was only noted as an ulnar fracture. So this is this classification helpful? And that is why we're missing a lot of these Monteggia fractures now. So this is a case in point. This was a 7-year-old child who presented with this lesion. He had sustained a plastic deformation and a Monteggia fracture which was missed at the time. He was only treated for the ulnar injury with a plaster. And then when he was reviewed by another surgeon, this was the treatment done at that time. So the surgeon attempted to correct the ulnar bone deformity. This fixation was done and the radial head was still dislocated. So what he did was he went back in, instead of opening the radiocapsular joint and clearing the soft tissue, he simply removed the plate, put a transcapitular wire, removed this plate as well, and then put a wire there and kept this tension on wire. So really, I don't know what happened. These are the x-rays which the patient came to show me, but there was no scar on the lateral side. So it was all from one incision. This was this presentation clinically when he came to me. So the head is become enlarged. So this is now 18, almost 20 months post the second surgery. And he was complaining of pain on the lateral side, which was also coming down to the arm. He had some weakness of the posterior interosseous nerve, weak extension, but he had decent movement. But only thing was he was having pain with activities. Now the dilemma was whether to, so this was how he presented to me, with the BOS still persisting. This after 2 surgeries, the head had overgrown, there was a radial angulation as well. His range of movement was fairly okay. There was mild weakness of extension. And so these are really the option of treatment. Either leave it alone, just decompress the nerve, or do a radial head excision, or do an ulnar osteotomy with ligament reconstruction. So he's 20 months down the line. And if anybody wants to share the experience, anyone to comment here what they would do at this stage? Or should I just go ahead?
Mandar? If Mandar is not there, Dr. Rujuta? Your comments?
Can you hear me well?
You can stop your video so that your audio is clear. Meanwhile, Swapnil, can you comment?
Yeah, so this is probably the boat has been missed and we are too far away from the shore right now. Even if we do an ulnar osteotomy at this stage, getting the radial head back in may be a difficult proposition. Even with the reconstruction of the annular ligament, the reason being is that there is a lateral overgrowth of the proximal radius leading to, angulation. So this is a difficult situation. All in all, probably try and be a little more conservative here rather than trying to attempt something heroic and cause more elbow instability and more elbow stiffness. I would probably be conservative here. Having said that, primarily Monteggia injuries are something one has to look at them, one has to find them, because if you don't look for them, you'll never see them. So this is what my opinion is.
Yeah, Rujita.
My voice is clear enough, then I agree that it's gone a little beyond.
Your voice is breaking. Can you stop your video and be on only audio? Yeah. Yes, better. Speak louder.
It's definitely a little difficult as a reconstruction option. But still, if you really look at the chronology.
I'll just go ahead. Is it okay?
Wait a minute. She's commenting.
Oh, sorry.
Rujuta, can you speak little louder?
Chronically dislocated, it's never been in, the radial head has never actually gone in. So if you want to reconstruct it, you could try re-osteotomizing and using a fixator for length, because what has happened here is the ulna has grown short.
Okay.
Ulna
so she
has
says,
lost length, so you can use fixator.
Okay.
For osteotomy.
Now, her comments are, it was never relocated properly, and with the proximal ulnar angulation, it has dislocated more. And she recommends ulnar osteotomy and lengthening of the ulna to contain the radial head with a fixator. Atul, is this a normal sequelae wherein the ulna angulates laterally and that pushes the radial head out?
Yeah, so this is a type 3 Monteggia where you get a lateral angulation and lateral subluxation. And I've got a case which I'll show later how you can treat this acutely. But this is not uncommon. The problem here was it was never explored on the lateral side. So when I go to the treatment, I'll just discuss that. But it was not managed at the outset in a proper fashion. The head was never located back. So that's why this kind of failed.
Can you go ahead?
Yes. So this child, so typically we would approach them. So I did a counseling with the family, and then we discussed that I may try and locate the head back in. It's almost 2 years. There are some papers from Korea that you can attempt up to 24 months post Miss Monteggia. So we went ahead through this Boyd's approach between the Anconius extensor approach, where we could also harvest the graft from the lateral slip of the fascia. This is not this child, but this is my technique where we would put the wires parallel first, do an osteotomy, correct the deformity in the plane, apply the plate, and then see the radial head reduction. So you must open the radiocapitellar joint from the same approach, clear all the fibrous tissue so that you clear bed for the head to sit in, and then you do the osteotomy, distract it, and then see the head going back in. And typically you can check the pronus in supination at this stage. But in this child, because he was already 24 months, I harvested the ligament and we did a ligament reconstruction. And this was his, so this was the X-ray post-op. Whenever there's a gap more than 7 millimeters, I use a corticocancellous graft. If the gap is less than 7 millimeters, you can use some kind of synthetic graft. So this is a child who presented later. He also came back for implant removal, and you can see that the head, which was here, is not perfect. but his symptoms of nerve went away. He still had restricted movements when he came for implant removal 9 months down the line. So he's now still undergoing physiotherapy. I'd counseled them preoperatively that he may not recover the full range of movement as well, because following surgery, he was in a cast for almost 6 to 8 weeks. And then they usually lack some pronation towards the end of the rehabilitation. This was acute injury which came to me, a similar case. And I would, he also had symptoms of posterior interosseous nerve. And we did an acute osteotomy, closed osteotomy percutaneously, and put a wire inside, ulnar nail. So this is how one should manage an acute injury. If you leave them alone, chances are they will, the head will subluxate outside. And why do we miss these Monteggia fractures? Because the classification at the outset doesn't look at the radiocapsular alignment. It always says about the ulnar fracture only. So every ulnar fracture is a Monteggia unless approved otherwise. So one must look at these 4 factors and make sure you don't miss any Monteggia fractures. And we did our own research and we realized that many of the ones who are green stick, they tend to get missed. The ortho consultants tend to miss them more. The residents are slightly better in terms of picking up the dislocation. So there are a number of factors. Children more than 7 years, green stick fractures. If the disruption is less than 50%, you tend to miss them because of poor X-rays, and only missed by senior doctors because they're busy in practice. They tend to just see the ulnar fracture. So this is my conclusion, that every ulnar fracture, you think of it as a Monteggia, do X-rays of both the proximal and the distal joint, and then only treat that forearm fracture. Thank you very much.
Atul, what happens at this age? Do they redislocate after 2 years, 3 years during the spurt?
No, so if you've got adequate fixation at the first time, and on table you have good stability, then they will not redislocate. So I think the key is to get the ulnar distraction osteotomy. You should get adequate ulnar length. And one of the tricks which Rujuta said, you can use a fixator. But I've got cases where people attempted a fixator, unless you have a hinge fixator. A straight fixator can cause, it can bend the pins and the head can come out. So I've got some cases where a fixator has failed as well.
During the osteotomy and fixation, you are given a little excessive posterior angulation. Is there a specific reason for that?
Correct. So typically you must angulate about 15 to 20 degrees so that posterior angulation pushes the head back in. And one of the theories is that you don't need to do a ligament reconstruction because you have a pull of the interosseous ligament. And we had published a paper 2008 where we had shown that we don't need ligament reconstruction every Monteggia fracture. So if they're presenting more than 12 months, 18 months, you may need to do it. And that can be an intra-op assessment. So every child, you should not do a ligament reconstruction.
In your case, where the head has remained out for almost two years, am I right?
Correct. Almost 2 years. Correct.
Okay. So it has angulated lateralwards. So probably the angular angulation was at the metaphysis.
Correct.
Now, if, how will you correct that, or how will the radial head contain in the capitellum where there is an angulation? It will always remain out.
Correct. So if you see, we've actually corrected the ulnar bow. I didn't want to do a radial head or radial osteotomy because the head had overgrown. So even if I did an osteotomy of the radius, the head had actually overgrown because of the previous transcapitular wire and it being subluxed. So even a radial osteotomy here, if you look at the intra-op X-ray, the radius is actually well aligned. The head actually was very large, and hence you see that residual subluxation on the X-ray. But his symptoms disappeared, and that's why doing 2 osteotomies at this level, there's a fear of causing a synostosis and more problems. So I didn't want to do that.
Okay.
I think one more thing one needs to remember is that when the radial head is out for more than a year, the concavity which articulates with the capitellum is also lost. So this is almost a flat or a convex head, and many a times putting it inside is also, it doesn't stay stable unless you do a reconstruction of the annular ligament. Now my question to Atul is, which are the neglected Monteggias where you preempt annular ligament reconstruction? Because the approach can be a little difficult, a little different, and you may have to plan it. So which are the ones where you decide that in this particular case, I'm going to do an annular ligament reconstruction?
So typically, if they would come to me, within 12 months with this technique where we do the intra-op osteotomy and we actually distract on table with the lamina spreader, and then you can check your pronation supination. If it's stable, if it says stable, you can go ahead and just fix this. If you feel the head is subluxating, then I would do a ligament reconstruction. And I found that children who present much earlier, like I'll show you a case, like this child had a fracture like this. We didn't do any ligament reconstruction.
Right,
You actually have to over-angulate,
Absolutely.
which Dr. Sangeet mentioned. You do almost 15-20 degree angulation and then decide whether the head is stable or not. So it's an intraoperative decision. I don't think you can preempt preoperatively, but if it's presenting within 12 months, certainly I would not do a ligament reconstruction if I get a decent stability on table.
Okay, I just want to make a point here that I have had a case where I done an angulation osteotomy, following which there was a slight posterior subluxation which I had to revise. So that's also something one needs to remember. Shouldn't be overzealous in your corrections as well.
Correct. I agree. That's a good point.
Yeah, and delayed union of this, unless you put a graft there, is also a very common problem, because unless you put a graft there, these kind of heal in a very delayed manner.
Just one quick this thing. See, if I feel as Sangeet was saying, the lateral angulation was excessive and overgrowth was excessive. So whether the radial osteotomy along with shortening would have reduced your amount of distraction and would have reduced your amount of angulation. I considered that.
Right.
With shortening of the radius.
No, I take that point. I didn't want to do the radial shortening because already the two surgeries have already been done. And if I do a third surgery which would have failed or would have caused more problems, more stiffness, then it defeats the purpose. So I had to I counseled the family that when I open the joint, I'll come to know. And like Swapnil said, that the cartilage was not very good. So that's why I told him post-operatively, he may end up with some flexion deformity and some lack of extension. So, 2 years, one could say you could leave it alone, to be honest, and let it, but because he had symptoms of the posterior interosseous nerve, that's why I had to go in.
Okay. Thank you, Atul. Parag, can you conclude the case?
Yeah, Atul, thank you. So, did the PIN recover, Atul, finally?
It recovered completely. Yeah.
Okay.
Can you put a fiber wire around the
Atul,
radial
unshare
neck?
your screen.
Yeah. Can you put a fiber wire around the radial neck and tie it to the ulna?
Oh, sir, fiber wire, I have not tried, but I believe once you put something tight, it will cause osteolysis. If it's very, very tight.
Don't tighten it. Just tie it to the ulna. That's all. It will prevent the
I have no experience, to be honest. I have not any experience.
Okay. Thank you, Atul. Let's move on now. Next case is by Dr.
No. Hold on, Parag. We have BOS announcement.
Okay.
It's 11 o'clock. We will take Chetan's case after this.
Yeah. So, Dr.
I
Agnivesh,
hand over to Swapnil for some announcements of Bombay Orthopedic Society.
Yeah. Very good afternoon to all the members of the Bombay Orthopedic Society. I would request Dr. Agnivesh to kindly play the sponsors video first, followed by the announcements. Dr. Agnivesh, if you're there. Dr. Agnivesh?
He is not there.
No, he's there. Thank you very much, Agnivesh. With this, we move on to the announcements on behalf of the Bombay Orthopedic Society. I welcome you all to this last clinical academic meeting of this academic year, which is the Bombay Hospital meeting. Let me remind you that Bombay Hospital was the institution which won the Best Clinical Meeting Award for the last year, and they are doing the last meeting of this year. So I wish all the presenters and the head of department all the best. The Bombay Orthopedic Society has been extremely active in its academic programs, whether be it the clinical meetings, the master series, or the instructional courses. And we are coming towards the end of our academic calendar this year. Yet we have a few courses remaining, which are the GES course, which will be on in this February, the pediatric orthopedic course, which will again be in the beginning of February next week, and the basic laser, of course, with which we will end the instructional courses for this year. In addition to this, there is also a research methodology course which is coming up in February again, which is meant for residents and people who want to kind of revise their knowledge about research and publications and presentations. So that's also there. Please remember that all these courses are very well subsidized, and even for our members, they are more subsidized. More than that, we are still accredited to the MMC. So there are MMC points for these. So anybody who does not have or needs MMC points can register, can learn, and can also get valuable MMC points for this. In addition to this, we have a wonderful master series coming up. This is on hand surgery on the first Sunday of March, which is 6th of March 2022. This master series is going to be conducted by two absolute masters, Dr. Sudhir Warrior and Dr. Hemant Patankar, and we are looking forward to a fantastic dynamic program. And I welcome you all to register in advance for this master series. Last but not the least, at the end of our academic year, we are having WIROC Global, which promises to be probably the biggest WIROC which you've ever seen till date. It is going to be from the 25th to the 27th of March, where 24th of March, that is a day prior, is going to be live surgeries. So we are coming back to you in a bigger way, Bombay Orthopedic Society, in the form of WIROC Global. I request all of you all to kindly register for this conference in large numbers. It's a physical conference. It will be at the Renaissance Convention Center in Mumbai. The dates are 24th to 27th of March 2022. Register for this conference. Tell your friends, colleagues, residents, fellows. Everybody has something or other to learn from this conference and take away from this conference. And I wish all of you all the best for the coming academic year, and see you guys very soon at WIROC Global. Thank you so much.
Should we break for 5 minutes, Parag? We have to now take cases from outside institute. The first presenter is Dr. Mohanty. And then we again come back to the host institute.
Should I share my screen?
Yeah, please.
Am I visible and audible?
Yeah.
Okay. Good morning, President Sir and dear members. I am really grateful to Bombay Hospital and Bombay Orthopedic Society for permitting me today to present this case. Most of you must have come across, of a case of osteoarthritis along with fractures in the lower end of femur and upper end of the tibia. But this is something, osteoarthritis with a fracture of the patella. That's what I'm going to present today. Now, my patient is 85 years old male, hypotensive, with normal BMI, slightly on the higher side, but normal BMI, sustained a trauma due to left knee due to slip and a fall, and presented almost 3 weeks after the fall. He had a history of pain in the knee before the fall and having difficulty in ground level activities, and he was suggested some surgeries which he was avoiding. These are the X-rays which he presented with AP, lateral as well as skyline view. And as a routine workup, we do USR CRP for every patient, and those are the ESR CRP. Now, anybody would like to comment what to do?
I would. Is there a depressed lateral condyle fracture as well?
No, there was no tenderness. That is part of the arthritic knee because of osteophytes and all these things. A straightforward transfer fracture of the patella with the arthritic.
Do a CT scan and fix the patella. CT scan, I would feel, is a must.
CT scan for?
Yeah, well, all that you can see microfractures, which is suspected, as you said, on the lateral condyle, that I also feel so.
How much was the symptoms of arthritis before the fall?
His joint is good.
He told that, I was having pain in this knee and I was having difficulty in ground level activities, that unable to sit cross-legged, squatting and all these things, which he was avoiding, but he was not amenable for surgical intervention before this fracture.
Why was
it a
patella?
valgus knee?
Sorry?
Was it a valgus knee?
It's not a valgus, it's maybe, alignment is pretty okay. But this is a supine X-ray, this is not a standing X-ray. So because his knee was little flexed because of the fracture, so we couldn't take a, proper standing view X-ray.
You normally don't take a skyline view for a patella fracture. Here, why specifically?
No, because of arthritic knee, we took a skyline view, and skyline view, as you can see, that petrofemoral joint space is reduced, and there is osteophytes in the laterally.
It won't represent the true skyline view, no? Because patella makes the knee to migrate up.
It may not be, but somehow or other we tried to take it because a part of the evaluation process for the total knee also.
So your plan is already set. You already set to this, do a replacement. That's why you did the flexion view. Otherwise, patella is just incidental here then.
No, you just patient never came to us for total knee before the fracture. It is just first time we saw the patient.
Yeah, so we are treating the patella fracture. So my question is, why evaluate for a knee replacement when we are treating for the patella?
That's what I did. Means what you do. I'm just asking opinions.
One general question, Dr. Mohanty. How can you flex so much a painful patellar fracture for a skyline view?
It was almost 3 weeks post fracture presented, so that was okay managed.
If he asked me, my plan would be to fix the patella only, and I would never evaluate him for a knee replacement, at least as of now.
Okay.
Second part, the
I
incision.
agree with you.
Harshad, incision.
Incision straight vertical midline. That is my incision for all patellas nowadays.
Dr. Mukhi, any different opinion?
I agree with Arshad.
Okay.
May
Hemant?
I just interrupt? There are a few YouTube questions which have come up for the previous presenters. If you can go to YouTube and just answer them, that would be good. People are asking.
See, if the patient was significantly disabled because of the arthritic pain, then we should counsel him to get both things done, fix the patella as well as the change the knee in one unique surgery. Both could have been addressed too. But if he was symptomatically disabled enough to do that, then I think it is warranted. Yeah, and as see, in very elderly, very osteoporotic, comminuted proximal tibia fracture, rather than fixing the fracture, it is many times opted to do a knee replacement surgery in order to mobilize the patient, get them walking the next day. We say about 80-90-year-old, very osteoporotic, comminuted proximal tibia, we go for a knee replacement rather than same would be true maybe in this case if he was sufficiently disabled.
The patella will not unite.
Hemant, would you do the...
With knee replacement, the union will go down.
It is a matter of good. I think Dr. Mohanty is a very good surgeon. He will fix the patella very well, I would expect.
Yes, but when you do the cut of the patella to replace the patella, it will destroy the vascularity. So you have to do a patella sparing knee joint.
Sir, use the incision. The patient has already done the half the incision for you, and his patella and retinaculum is already. I think you should be able to get it within that. Reflect it. It should be possible to do it.
Possible, but the union is not
Dr.
possible.
Mohanty, you have only 10 minutes. There are 4 other speakers,
Yeah.
3 other speakers.
So,
Can you go ahead?
I'll go ahead.
Yeah.
So as suggested by the panelists, so there are 3 options now. So do a 2-stage surgery, as Harshad and Dr. Mukhi pointed out, do a open reduction internal fixation of the patellar fracture. And the second stage, if the patient is symptomatic, then do a total knee replacement later on. The second option is do a single stage total knee replacement plus open reduction internal fixation of the patella fracture without resurfacing the patella. Just leave the patella intact. And the third option is the total knee replacement, do a fix the patella and with a patella resurfacing. So my option was, I always go with my guru, Dr. Ranamat, who always resurfaces the patella, and I also do that. So I prefer the option of doing a totally replacement, open reduction, internal fixation, as well as patella resurfacing. So this is the operative procedure. This is after exposure. This is the gap in the fracture site. Then we reduce the fracture with a reduction clamp and use this number 2 fiber wire and Marcelin tapes to reduce the patella as we do for a Krakow suture for a lower pole patella fracture. So this is passed, the guide wire is passed, and then pull through sutures were placed. And while passing this guide wires, we took little care to pass it little towards the anteriorly rather than coming towards the articular surface. So in 2%, and then we do a figure of 8 anteriorly. Unlike this picture is a different picture, just to show this a diagrammatic representation. So number 2 fiber and Marcelin tape was used. Then it was took out and tied at the anteromedially near the anteromedial pole of the patella. So patella was reduced. Then we measured the patella, it was 25 mm. Then we took the cut. After cut, the thickness was 17 mm. Then we took multiple drill holes to place the patella. As you can see, a part of the fiber are little visible there through one of the holes. Next, we put the patella, and here we took little. Normally, we put the patella superiorly as well as medially in order to have a good tracking. So we put little bit downwards so that it is located at the center of the patella before preparing the patella, and the final thickness was again 25 mm. Then we did a total knee replacement and did the cementing of the patella. This was tracking before tunicate release, and this is the tracking after the tunicate release. So there are slight maltracking which got corrected after the release of the tunicate. And this is the post-operative X-ray, and intraoperatively we checked the stability of the patella, which was quite stable, intraoperatively. And this is the post-operative X-ray of this patient. So there are only two case reports which has been described: osteoarthritis knee with patellar fracture in elderly. This is a 2007 case report in Journal of Arthroplasty, where the patient was a 78 years old male. Total knee replacement done and fixation with non-absorbable pull-through sutures were done, but no resurfacing was done. 2 years follow-up showed that the fracture got united. The another case report is recently from Dr. Guruva Reddy's group in Journal of Orthopedic Case Report in 2018, where there is a 65 years old male. They did the total knee replacement and fixed the patella with tension band wiring without resurfacing of the patella. And they had shown a 3 months follow-up where the fracture is united. So our patient has been done recently now. So the take-home message, it's a case of osteoarthritis knee with patellar fracture, which was presented in an elderly person of 85 years. We did a single stage total knee replacement with fixation as well as resurfacing. Patellar resurfacing is possible with a stable fixation. We are awaiting the follow-up. I thank you for a patient here.
Thank you very much, Dr. Mohanty. Mandar, can you share your screen? Quick comment from Dr. Mukhi. Yes, sir, please.
You should have taken from quadriceps to tibial tubercle one circumferential stitch, or must include the tibial tubercle to be 100% sure. Otherwise, you are going to land up with non-union and opening up of the patella. This is what my prediction is. And I will be very happy if you show me the case after another 3 months. This will not unite because the gap is opening. See the X-ray. Post-op X-ray, the gap is open up.
Excuse me. Hemant.
Yeah.
If you ask question to Dr. Mukhi, he will not be able to present his last case. We will not allow him to present.
No. We must hear from him.
Yeah. Okay. We close this case. Move to the next case from Mandar. Go ahead, Mandar.
Yes, sir. Am I audible, sir?
Yes.
Yes, sir. So I would like to acknowledge my co-authors who helped me with this case. So this was a 12-year-old male, incidental history of an acute lymphoblastic leukemia who had completed his treatment. and had a cervical lymph node biopsy done about a year back along with other biopsies. Had progressive weakness, abnormal movement, and a lump formation or a mass formation on the anterior aspect of the shoulder since then. There is no relief on physio, and the deformity and abnormal movement has been progressively increasing. As you can see that there is this mass which is seen in the axilla, and on abduction you can see that there is this significant mass right here, and probably a sulcus sign which is seen. And this is how he was moving. So at about 80 degrees of abduction, there was this big mass which was being seen on the anterior axillary line, and he was doing some trick movement in the scapula. He was having a good amount of retraction and good retraction power. So we initially thought that there is some mass which was related to his acute lymphoid leukemia, and that is why we got first the X-rays done. So this is the X-ray at neutral position. This is the Y view, which is again showing a reduced shoulder, and this is the X-ray at the time when he is doing that trick movement. Again, nothing remarkable which I could actually see. We got an MRI done exactly where the mass was, we felt was the mass. Again, nothing on the MRI. This was the incidental surgical scar of the lymph node biopsy. So I would like to ask the panelists about what is the diagnosis, any other investigation which we need to do. We'll just have a quick one or two, then I'll go ahead, sir.
The mass was a solid mass, was a soft mass.
So it was a solid mass which was moving with the rotations of the shoulder, which was appearing at around 80 degrees of abduction, at which time he was doing that trick movement in order to get further abduction.
It was mobile from the underlying structures or free from the bone?
Sir, it was moving with rotation of the shoulder. It was feeling like a globular mass.
Mandar, what was happening at that 80 degrees? Was the head subluxating?
Subluxating out.
And do you have any glenoid view? Any view of glenoid in the MRI or X-rays?
Yes, sir. So what was happening is, retrospectively, what we found was at around 80 degrees of shoulder abduction, he was doing an external rotation and slightly popping the shoulder anteriorly, and then he was taking the entire shoulder up. So the glenoid, the humeral head was unable to go beyond 90 degrees, and that is where he was externally rotating so that the greater tuberosity slips down, and then he was able to do that trick movement in order to abduct the shoulder. So again, we were unsure of what to do. Thankfully, we got an EMG NCV done, and which showed a complete denervation of the spinal accessory nerve, especially the upper fibers which were supplying the upper fibers of the trapezius. This was probably related to the cervical lymph node biopsy. As you can see, the surgical scar, it was more than a centimeter distal to the mastoid, which is a very danger area for the spinal accessory nerve. So now we know that this is a trapezius palsy. So what do we do? Anyone from the panelists can opine?
Mandar, you have
Yes,
only 7 minutes for presentation.
Yes,
Please go ahead.
Yes,
We'll
so this
discuss
was-
at the end.
Yeah, so I would like to thank Dr. Dipit Sahu, who gave me directions in this case. So there is a very good transfer, which is known as an Eden-Lange transfer, which is specifically for spinal accessory nerve. So what happens in the Eden-Lange transfer? So in this method, in this palsy, the scapula is unable to rotate. And so you use the rhomboids and the levator scapulae in order to help that scapula to rotate at around 80 to 90 degrees of abduction. And the rhomboids helps to prevent the winging of the scapula at that time. So I'll just go for the intraoperative pictures. A a medial parascapular incision is taken. This is the trapezius which has been lifted off. You can see the rhomboids major, the minor, and the levator scapulae. The rhomboids minor and the levator scapulae is taken en masse and lifted off the medial border of the scapula. Along with that, the rhomboids major is identified and it is lifted off with a sliver of bone. The infraspinatus fossa is completely denuded, and drill holes are made with ethibond sutures through it so as to have a recipient bed for the rhomboids major. Along with that, the spine of scapula is then exposed and a subcutaneous tunnel is made so as to find a recipient zone for the levator scapulae and the rhomboids minor, which will help in elevating the scapula. This is what it's done. And then the rhomboids major is sutured back to the scapula in the infraspinatus fossa. So this is after the closure of the trapezius, and this is the skin closure. Cuff and collar is given for about 3 weeks, after which abduction exercises are started at around 3 weeks. This is the 3 months follow-up. You can see a good shoulder contour. He has full abduction with disappearance of that mass. And you can see that the entire trick movement which he was doing is completely disappeared. He is able to do this full abduction. Even posteriorly, the scapula, which was getting locked at 80-90 degrees of abduction, is completely relieved. And you can compare it with the pre-op and post-op videos. It is completely relieved of that shoulder swelling. Any comments, sir?
Excellent.
Excellent presentation on that.
Thank you, sir.
Excellent.
One question, can we do something to renervate the spinal accessory? Is there any procedure for that?
So first of all, it was almost a year since that lymph node biopsy. So any nerve reconstruction usually should be done within the first 6 to 9 months. So that is one thing. Secondly, we were thinking that it must have been a complete transaction at that time, because the location of the surgical scar was right at the level of the spinal accessory. So that is why
diagnosis, excellent management.
Okay.
Thank you, Mandar.
One lesson you have learned is not do a biopsy, but do a needle biopsy. Don't
Thank
do
you very
open
much,
biopsy.
Dr. Mukhi. Thank you very much, Dr. Mukhi. Mandar, unshare your screen.
Yes,
Parag, your comments, and please share the screen for your case.
Yeah. Yes, sir. So to consider a nerve transfer for spinal accessory injury is not advisable, because spinal accessory is our important donor in brachial plexus injuries. So only when you get spinal accessory nerve injury, muscle transfer is the only option. Okay. So can I start sharing my presentation?
Yes, please.
I thank Bombay Hospital for giving me this opportunity. I would like to acknowledge Dr. Pankaj Ahire's help for solving me this case. 27-year-old gymnast, female by profession, right hand dominant. She presented to us 3 months post-fall while doing gymnastic injury, and her chief complaint was on attempt of movement, there was a pain and grossly restricted pronation movement, which was affecting her activities of daily living. And this was the full supination and grossly restricted pronation movement. And this was the degree of wrist flexion and extension on movement. And these were the X-rays. The X-rays of the wrist were taken in AP, lateral and supinated and pronated oblique views, which showed a volar or palmar dislocation of distal radioulnar joint with no fractures. So usually dorsal dislocations are very, very common, but in her case, the dislocation was volar. So may I request, seniors to comment, or I should continue presenting?
Please go ahead. Please go
Okay.
ahead. We'll discuss
Okay.
at the end.
Okay. So as the injury was 3 months old, our clinical diagnosis was very obvious that patient had a palmar dislocation and there was no movement, no pronation possible at all. So the MRI showed remnants of TFCC, with frank tear of the triangular fibrocartilage ligament complex, and the arrows that are shown on the images below is suggestive of a dislocated ulnar head from the sigmoid notch of the distal radius. So in this case, we had, there was a full thickness tear on the dorsal radial ulnar ligament also. So here the option and approaches where now the issues is, first of all, palmar dislocation is relatively rare, and to manage it at 3 months post fall in a gymnast is more difficult. And gross restriction of pronation, we need pronation for practically all the activities. We need supination very, very rarely in our activities of daily living. And especially in a gymnast, pronation is extremely important. And of course, if we do not solve this issue at the right way or in the right time, then there is a possibility of in future Diarrhea arthritis and ulnar nerve compression in the Gans canal because of the dislocated ulnar head on the volar side. So we decided, and given the approaches we had discussed, so as it's a volar dislocation, we had to go on the volar side. The another issue was how to maintain that dislocation once you reduce it, by putting a transverse K-wire or anchor or with a tendon reconstruction to repair the TFCC. And we had discussed about chances of recurrence even after we fix it, because it's a 3 months old injury. So this is how we consider a palmar dislocation of ulnar head, and the exposure on the palmar side. The arrow is showing dislocated ulnar head. Pronator quadratus was pristinely normal, and there was a breach of capsule on the volar distal radioulnar joint. Now the volar exposure, and what I am seeing, I mean, we did a arthrolysis of distal radioulnar joint from the volar side, try to debride the fibrotic tissue properly, and then try to reduce the joint. Okay. So this is how we debrided the, the remnants of torn TFCC and fibrotic tissue and tried to reduce the joint. Once we did that, then we identified the TFCC torn complex. What I am doing here is, I am pressing, I am putting a wire and confirming the triquetrum here. And then I am going proximally till I see a soft tissue where the wire can go in. So the TFCC lies between triquetrum and ulnar head. That is the marking that I want to show here. So this is my first point from the triquetrum. Okay, and this is the whole TFCC ligament complex. So whenever we want to confirm how to identify a TFCC as a structure, we should go from triquetrum and come proximally till the ulnar head, and the component in between is a TFCC ligament. So after that, we did once we know that we could attempt a reduction, now to hold, we had to do a repair of TFCC. So this is how we use the TFCC suture anchor, which we fixed it into the ulnar fovea. And then we repair the volar part of triangular fibrocartilage ligament capsule. And apart from that, so once we repair the TFCC, then the torn pronator quadratus apart from the capsule was also repaired nicely. And this was the pre-op X-ray, and that was the immediate post-op X-ray, which shows DRUJ well in place. The suture anchor was perfectly into the ulnar head and fovea junction. And the rehabilitation protocol was followed as mentioned here. Above elbow slap for 3 weeks. Then a cock-up splint after that for 3 weeks. We started active movement, flexion extension at 3 weeks. But pronosupination we started at 6 weeks. And then 8 weeks onwards, we started passive mobilization of pronosupination. And this was the follow-up at 10 weeks. The joint looked well reduced. Suture anchor was well in place. And this is the 8 months follow-up of the patient, where the reasonably good amount of pronation was achieved, and she was back to having a normal wrist flexion and extension movement. So this was the follow-up. And the literature, mainly volar dislocations of DRUJ, there are only case reports. Nobody has a series about it. People have discussed options of anchors, then TFCC reconstruction with tendon reconstruction, and transverse K wires fixing the ulnar styloid to the ulnar head. So this is one case report about managing the volar dislocation. We had counseled the patient about the tendon reconstruction. And this was the second case report that I found useful pertaining to this case and recently published, that they did a suture anchor. They used suture anchor to fix the TFCC and reconstruct the TFCC ligament around sigmoid notch. But we did not have to do a tendon reconstruction, as our reduction became very stable after a thorough arthrolysis of DRUJ from the volar aspect. So these were the case report which I discussed.
Thank you, Parag.
Yeah, thank you so
Parag.
much, sir.
Yeah,
thank you.
Dr. Mukhi, sir, please share your screen. And the convener, Dr. Parag Munshi, has conveyed that please give only 5 minutes to Dr. Mukhi because he has asked too many questions.
Any role of arthroscopy, Parag lad?
Sir, not for volar dislocation and not for volar dislocation. Dorsal, yes. Yes, sir.
Thank you.
Thank you, Parag.
Thank you, sir.
Dr. Parag Munshi, any questions to Parag?
No, it's a very nice case. It's an unusual presentation, and you'll have had a very good outcome.
Thank you so much. Thank you.
This is a 13 years male. He is Desire is to become a national athlete, presented with severe low back pain, and was diagnosed as osteoid osteoma of the left pedicle of L5, and was treated somewhere else initially by operated radiofrequency ablation, endoscopic, and the needle broke inside and the procedure was abandoned. One can see the needle just very clearly on the X-ray. And this is the CT scan, which shows a broken ablation or ablation probe that is broken, plus the osteoid osteoma still persisting. He has severe pain. And now, this is how I inherited the case. This was the Mars MRI, which shows a little fluid collection. And this is the patient, what to do, and why the RF needle broke. And patient wants to go back to the national, become a national athlete.
Dr. Mukhi, what are the complaints now that the patient has?
Severe pain, not able to sleep. Osteoid osteoma is persisting, daily analgesics.
Hey, can you go back to the axial sections, CT?
Yeah.
So, this is a very misshapen pedicle. This patient, so there is a sclerotic margin all around the osteomyelitis.
Yeah. Any suggestions, sir?
I really doubt whether it's osteoid osteoma. It may easily be osteoblastoma already, considering the size of the lesion.
No, it is less than 1.5 centimeters reported on the CT scan.
But 1.5 centimeters is not a cutoff for osteoid osteoma, sir.
2 centimeters is cutoff, the literature says.
2 centimeters?
Yeah.
I really doubt, sir. Maybe I'll have to revisit my understanding on this.
Please.
Dr. Mukhi, when was this? How many years back?
This was about 4 years.
So do you have a recent CT?
I will present it. I want the opinion of the house on this, what to do.
Dr. Mukhi, sir, please complete your case and we'll have the discussion at the end.
Okay, sir. This was the osteoid osteoma, right? And CT is diagnostic. This was the plan. This is the needle which is broken, or the probe which is broken. And I made a little burring down the red area, removed the needle or burred the osteoid osteoma. This was my plan. I used Mesonex. This doesn't touch the nerve. Even if it touches, it doesn't harm the nerve. And I practiced it on a bone model, right? And here is the nerve. And this is the post-op result. Immediate X-ray. This is his walking, which was very difficult. He's bending. This is the post-op X-ray, right? And you see the way he's running. Video. See the running. He wants to become a national athlete, and he's so happy. This is 2-year results of that national athlete.
So do you have a recent post-op CT, doctor?
He says, I don't need it. I'm totally fine.
No,
why should I spend money?
He doesn't need it. We need it.
Yes, we need it. I agreed. I told him, please send me the CT scan, latest CT scan.
Sir, your hospital
I will send you the needle.
Yeah, you should have called him.
Sir, आपके hospital में है ही free कर देते sir.
Sir, you can run it free. Your own hospital for study's sake.
So, Dr. Mukhi,
he says out of Bombay.
Anyway, so coming back to the options of treatment, sir, I think the size does matters, and to me, I think anything more than 1 centimeter, I would rather go and excise it completely. But yes, what you have done is also is surely an ethical and scientific way of dealing with any osteoid osteoma. Probably in our scenario, I would have done it navigation guided Midas drill burr. Arvind has also published one case of C7. I have published a case of osteoid osteoma excision and using navigation guided burrs with the tubular technique, one stitch incision in C1 also. So we have a big series of such osteoid osteomas being done with navigation guided stealth burr, just going and burring and creating a hole like you did it with Metonics in a minimal invasive manner. So that is one sure shot option that we could have done.
That was tried by the spine surgeon twice.
No, sir, no. It was tried. Radio frequency ablation was tried. A radio frequency ablation is not equal to navigation stealth burring of the osteoid osteoma, which is a navigation guided procedure. It is not
but once the needle broke, he came out.
No, this was a RF needle. Dr. Mukhi, you are confusing between a burr and a RF needle.
No.
In the last BOS meeting, you see, I showed a L5 pedicle, S1 pedicle osteoid osteoma, which was similar to this. If you remember last BOS meeting.
Yeah, I agree.
So what Dr. Vishal is trying to imply is that, RF is done by coax. So this is totally different. That is, you cannot remove the entire osteoid osteoma, nor can you biopsy it. It is just a touch and go. So here, after the needle is not giving the pain. The aim of surgery is not removing the needle. The aim of surgery is to see that the lesion is out. So I also feel that it was bigger than 1 centimeter. I wanted a pre-op CT after 4 years to see that it is not grown in size.
Exactly.
And if it is grown in size, unfortunately in this athlete, there is nothing except fusion that you can do. And that too, you'll have to bypass that particular level. So it will be something like a L4 to S1.
And he will not become an athlete.
Why not, sir?
Not necessarily.
Patel, I have done a fusion to him. No, sir, that's the wrong thing.
No, that's what he was
fusion
told.
Also, there are national athletes. Please don't take a notion that fusion, nicely done fusion, will lead to a prevention of any athletic activity. Is a wrong notion. Please don't.
Even with navigation here, see the pedicle is misshapen. There is a high likelihood that when you use the burr, it can go this way, that way, and cause pedicle fracture, and the patient may not be as asymptomatic as he is now in this magic video that you have shown.
No,
Thank you very much, Dr. Mukhi. We close the discussion here, as there are a lot of cases from host institute to be completed. Please unshare your screen.
Okay. Nicely done, Parag, nicely done. I mean, you should just follow it up long.
The next speaker.
Just follow this along, and maybe a long-term follow-up will really enlighten us even further.
Oh yes.
Okay. Thank you.
With the CT, he means.
Right. So we'll plug in back with the original order. We have a next case by Dr. Chetan Anchan, something on the tumors.
Hi, 1 second. Can you see me?
Yeah, enlarge the screen.
1 second. Yes. So thank you, everybody. I'll be discussing a patient with elbow giant cell tumor. This is a 32-year-old gentleman who came with complaint of progressively increasing pain and swelling around the middle aspect of left elbow. He has pain since more than a year, swelling since 4 months. He has severe pain now with limited movement at the elbow, unable to use the affected arm. He has no other major symptoms. That is his X-ray. There is a large destructive lesion in the medial condyle of the lower end of humerus with a huge soft tissue mass. So the differential diagnosis in this situation in a patient of this age is, first is definitely giant cell tumor of bone. The other consideration should be that whether this could be a sarcoma, whether this could be some form of infection, or this could be something else. The next investigation which we would definitely want to do in such a case is a MRI to see what is the soft tissue extent of the disease and what is the extent of bone destruction. So here we see this MRI of the lower end of humerus and elbow joint showing a large destructive mass. The medial condyle is practically entirely gone, and it is even encroaching into the olecranon fossa. These are the sagittal views, axial views. So MRI showing 5.7 by 4 by 6.8 centimeter expansile destructive lesion involving the medial humeral condyle with infiltration of the ulnotrochlear joint capsule posterior. So what next? It's logical. What we need to do is a biopsy, a needle biopsy. In fact, he had an open biopsy done elsewhere. It was reported as GCT of bone, which is an acceptable diagnosis for the clinical radiological findings that we are presented with. In any patient where there is a diagnosis of giant cell tumor, it is imperative that we rule out metabolic bone disease. So his calcium, phosphorus, and alkaline phosphorus levels were done, which were normal. So we have a diagnosis that is GCT of bone involving the medial condyle of lower end of humerus. What do we do now? Anybody would like to talk about it, or should I continue?
Dr. Mukhi?
Yeah, I would give him, first do his vitamin D3 and calcium levels and put him on denosumab, so that soft tissue regresses and it becomes an operative technique. I would do cementing in this with a hybrid, as Tata Cancer has already advocated hybrid with mesh and bone grafts and cement.
Denosumab is a dangerous, drug to use in treating giant cell tumor, because the point is, once we give denosumab and we do curettage after that, the risk of local recurrence is extremely high. The curettage becomes more difficult after using denosumab. So we are very selective with the use of denosumab in patients of giant cell tumor. In fact, in majority of cases, we would use it where we are probably planning a resection of that particular bone, especially in extremely large diseases where even a resection is risky or dangerous.
Chetan, was the elbow stable?
It was stable, sir, but it was so painful. I mean, he had very limited range and he was just miserable with this.
And the olecranon was absolutely normal.
Yes.
On the MRI.
Absolutely, sir. On the MRI. It was just generally these diseases don't cross the joint. It is very, very unusual. Only when they grow to a very large size or some intervention has been done, then we can have such challenges.
Can you go ahead?
Yes,
was the ulnar nerve involved over here, Chetan?
He had no ulnar nerve symptoms, but on the MRI, yes, it was sort of pushed to one side, not encased and not actually infiltrated.
I think for my choice, I would excise the entire tumor, use a burr, chemical cautery on the wall, and keeping the nerve in vision, try and put a cement there so as to reconstruct that pillar, avoiding the joint. That would be what I would do.
Okay.
What is the lateral extent? Because it is involving probably half of the trochlea, the coronoid and the olecranon fossa.
Yes.
As well.
In fact, only the radial half is intact. Here, what we are seeing is basically the edge of the disease. In fact, it goes all the way inside here, sort of hollowing it out, that part of the bone. In majority of lower end of humerus, in fact, any of these small bones, curettage becomes more challenging because you got very little bone to curate against, and especially in the bone with the anatomy of the lower end of humerus. It is unlike your distal femur, proximal tibia, where you got a lot of bone to work with. Here it is more difficult. In fact, in literature, majority of the cases end up with resection and megaprosthetic replacement, which is not really desirable in such young people.
Can you go ahead?
Yes, sir. So these are the options that we could think of. First is to decide whether you are doing a curettage or resection. If you are going to do resection, then you should think of your reconstruction options. Sorry. So the reconstruction options are either do a total elbow replacement or an elbow arthrodesis. If you're going to do curettage, which is extended curettage, when we say curettage, it is always extended curettage, not just a curettage. Then we have to think of the various reconstruction options, because just a curettage is not going to finish the job in this case. So these are the options that we could use. Either do cementing with fixation, do a sandwich reconstruction, which is not really suitable in this location, or a reconstruction with bone grafting. And when you think about bone graft, then you have to take a call on whether you're going to use autograft or allograft. If you're going to use autograft, whether it is going to be a fibula graft or an iliac crest graft, and what kind of fixation you're going to use, whether you're going to use stainless steel implant or titanium implants. And in this particular case, whether you're going to use a single plate or 2 plates. Now, when it comes to tumor surgery, is when we are going to use implants like nails and plates, I would always insist that it is always a good idea to use titanium implants because it is MRI compatible and it makes the follow-up of these patients much more easier. You can detect any relapse, much earlier. So that is what was presented to us for surgery. So what I planned for him was an extended curettage with iliac crest bone grafting and fixation. So at the end of this curettage, this is what was left with. The ulnar nerve was completely dissected out first, and then the entire soft tissue mass was excised because there was nothing to really curate out there. What was curated was the lateral half of the bone. So it was completely curated, burred, electrocauterized, washed with hydrogen peroxide, saline, whatever I could do. And following that was all the disease that came out of there. I did the reconstruction with a autograft using a large piece of tricortical iliac crest bone graft, which was carefully shaped by trial and error to fill the defect in the humerus, ensuring that I have good contact with the native bone on both sides. On the articular side, I could preserve the articular subchondral bone, and in some areas the cartilage was there, but there was no breach into the humero-ulnar joint. And then I have to provide it complete and rigid support with the help of fixation. So I used distal humerus anatomical plate. I used plates on both sides because if you see how the fixation is in the medial plate, the distal part of the plate is holding only to the graft. It is not going into the opposite cortex. Because of the angle of the plate, the screws would have come into the joint. So there was no way I could go across to the opposite condyle. So I used a plate on the other side. So that was the post-op X-ray of this patient. And he came for follow-up now in December. That is 7 months after surgery, and things look fine. The graft is holding well, the implants are holding well. Even the articular side looks quite well formed now. So that is his range of movement now. This is a video of his function. So you got decent range.
Excellent, Chetan.
Yes, sir.
What was the role of second plate? One,
yeah, I'll just go back.
And second is, what did you do to the common flexors and the MCL?
Right. Let me go back. So if you see this X-ray, you'll realize that the plate is holding on to the proximal humerus, the medial plate, and distally it is only holding on to the graft. That means the articular end of the bone would have been supported by only one column, that is the lateral column. So I was very worried that once he starts moving, it can just walk out. It could just fracture. So that is why I had to support that column with another plate. Because I wanted to mobilize him early. I didn't want to immobilize him. He was mobilizing within a day or two of surgery.
Chetan, do you use chemical cauterization, like for example?
No, not really. We have almost stopped using phenol, which was what the chemical we were using till a few years ago. But there is a lot of literature now which says that you don't really need to use phenol. The one problem with phenol is it is a corrosive substance. A lot of accidents do happen when you are using phenol. And the other thing is, you have to wash out that phenol with absolute alcohol on table. And what we realize is that the alcohol, can sometimes spill out of your field into the drapes, and then if you happen to use a cautery, it can actually catch fire. We have, a rare experience with things like that happening in a very
That's
limited manner.
exaggerated because we use spirit all the time. No? Spirit is alcohol. We do use spirit all the time.
Right. So, and moreover, when it catches fire, it is a very faint blue flame. You don't even, realize that there is fire. It is like that. So regarding the MCL and the common flexors extensor, I guess, origin, here what we do is we don't really do anything to that. We work from inside to out. So we stop where, the curettage or the excision of the soft tissue is over. We don't go from outside to in treating a benign bone tumor. Whereas if it was a malignant disease, then we would do a wide excision where we would leave a cuff of all the soft tissue around on the tumor and then excise it. In that's a problem. But here, somehow this, when it heals, all of them fall back into place, and he has a very stable elbow now, and he has no trouble with his hand functions.
Has the graft completely incorporated now at 7 months?
I don't know, sir. I mean, this is the X-ray. This is the best that I can read. Looks like it is at least, not separating. So I can't see any, lucent zone between the graft and the rest of the bone. But it is too early. I totally agree. More than that, and other than the graft, even as far as the disease itself is concerned, 7 months is just not enough time for us to conclude that what we have done is, successful or not. It will take another 4 years of follow-up till we can, be comfortable that he's okay.
So with the 2 screws in the graft, it is only, the plate is only buttressing it. The graft is not compressed to the host bone.
No.
So probably if you would have put longer screws, longer distal screws across on the opposite side, probably it would have, the graft would have been compressed to the host bone. That would have helped in.
Possibly, yes. I was very worried that, these screws, because these are locking screws, I have no way of controlling the direction or the trajectory of those screws. And I could see where they were exiting. So I was unable to get a purchase in the opposite condyle with these screws.
Chetan, one last question about this, not this GCT in any other area like distal.
Yes, sir.
Would you today recommend that you just do an extended curettage with burring of the walls and no use of phenol or any chemical content on the wall?
Absolutely.
And fill it up with a bone graft or fill it up with bone cement? So that's what we've been doing.
Yeah, see, I think, bone cement, especially in majority of cases, we end up actually using bone cement. And I think bone cement is a very good material to fill up large cavities, especially in the large bones, because you don't get so much graft to fill, because this was not really a cavity as such. That's why I prefer to use bone graft here. If it is a cavity which can contain the cement, then cement is an excellent material. One more advantage of cement is it definitely will reduce the risk of local recurrence of disease, because cement, when it cures, releases a lot of heat, and that itself has a sterilizing effect on any microscopic disease that may be there. Even the monomer of cement is supposed to be cytotoxic to GCT cells. And the other thing is, if there is a recurrence, it is much easier to spot when you have cement to contrast, the recurrence against. Otherwise, you will, definitely delay the identification of any recurrence of GCT if you have used graft.
So thank you, Chetan. We close this case. Final comments from Parag. Hetal, can you share your screen?
Dr. Chetan, excellent case. Just one last question, rather comment. Tell me, is there any data injecting bone morphogenic protein at this graft host bone interface to enhance healing? And does that actually increase the risk of GCT recurrence? Is there any data? Is there any?
No, sir. I am not aware of any such.
Sure.
Not really.
BMC can convert it into malignant.
No, sir.
Reported.
No idea. Really.
Reported in the literature. Anytime you use BMP, it has got a 1% chance of malignancy, and in osteoclastoma or giant cell tumor, chances will be high.
In fact, even
So
there
FDA,
is certain
FDA has not
concerns
given
about,
approval.
even there is certain concerns about denosumab also regarding the possibility of malignancy.
No, JBJS has given in a recent article that give 2 doses prior to surgery. Surgery becomes easier, and you can put even all these chemicals and use it as
No,
a
sir.
doctor.
There is a lot of counter literature to that. There is a lot of uncertainty about the exact role of denosumab today. It is totally a gray zone. There is no clarity about its role, but definitely the incidence of local recurrence is very high after using denosumab, and moreover, that recurrence can be quite aggressive. So that is another observation. So we are extremely careful with the use of denosumab.
Okay, lovely. Thank you, Dr. Chetan. Next,
thank you, sir.
Dr. Hemant, are you ready?
I am ready.
Okay.
Chetan, unshare your screen.
Yes, sir. I don't know why I'm unable to stop share. Yeah.
The cement, heat of the cement kills the cells.
Yeah.
Chetan?
Yes. And slideshow.
Yes, yes.
Hello. Yeah. So I'm presenting a case of a person who has an irreducible fracture dislocation. He came to us. He fell while running, and his foot got trapped by restraining rope of the bull. And he had a total talus dislocation, and there was some small comminution at the posterior medial aspect of the talus. And in the local hospital, they tried to reduce it by close reduction, couldn't do it. After 2 days, they attempted open reduction, and they managed to put it in some position and fixed it with K wire. And they removed the few loose fragment which was on the posterior medial aspect and kept it non-wet bearing in cast for 3 months. So after 3 months, they started to make him wet bear, but he came with a lot of pain, swelling, and unable to wet bear. So he presented to us with this X-rays. Any comments on the reduction or fixation? Anybody?
It is not reduced, and one has to do a CT scan.
Correct. So
still not reduced.
if you see the talus is, dome of talus is facing medially over the medial malleolus. So they were not able to reduce it, and they just fixed it with a wires and kept in a cast. So we did a CT scan. You can see the sinus tires are lying vertical, and the dome of talus is facing medially. So he came to us after 4 months after the surgery. And this is a CT scan which we have done. And when they came to know it is dislocated, he took many opinions. Many of the surgeons suggested fusion for him. But he did not want to agree for fusion. We found it difficult to classify this injury, but one of the possible classification we could use is the type 4 displaced fracture with dislocation through ankle, subtalar, and tibio-navicular joint. So we attempted open reduction by medial malleolus osteotomy, and after osteotomy and release, I was not able to reduce it. Then I had to go laterally and release through the sinus tracea as well and try to reduce it, but still it was not possible to do. After adequate release of both talonavicular joint and sinus tracea, I used a Steinman pin to de-rotate the talus, and the talus could be reduced. He ended up having these incisions. The one in the green is the one used by the previous surgeon, and the yellow one is the one I have used to open reduce the talus. And this is the intra-op X-ray.
the Steinman pin, which is looking quite vertical, I had to put it right in a distal position and then de-rotate it. And then I fixed the medial malleolus back to position. He was kept in cast for about 6 weeks. And then after 6 weeks, he was about to mobilize weight bearing. Since it was quite stable, I did not want to put any metal to transfix the talus. This was immediate post-op X-ray. This after 1 month. This 10 months. We looked for AVN changes or so, but I could not find. And there's a good range of movement. This is 10 months. He is able to walk long distance. He is able to work in the field. And he has minor discomfort. Ankle joint movement is painless, but he has minor discomfort in the subtalar joint. But he's not wanting any further treatment to be done. I think for any talus approach, we need to look for the blood supply and plan our incision and try and spare the whatever the blood supply of the remaining. In the literature search, there was hardly any case reports of 4-month dislocated talus which has been reduced or so. But literature search says that type 4 would have 100% AVN risk. This fellow at 10 months, is comfortable, but it's not showing AVN changes. But we'll wait and see in the future. So this is a rare injury, but can be reduced. And we'll attempt arthrodesis only if the joints become very painful and arthritic.
Dr. Junjunwala, sir.
Yeah, I had 2 cases of dislocation of talus, and by putting the femoral AO distractor, I tried to distract it and then reduce it. I could not do it. It requires both sides. Yeah, then I put bilateral LRS and distract it slowly. And then I could reduce the talus inside the space. And the LRS was loosened out and kept like that, plastered it for 6 weeks and allowed to walk. So 2 cases I have done it, but it was painful.
So it's a rare case for a.
Yeah. So most important is the tibialis posterior tendon, which gets entrapped. Moment you release that tendon, the reduction becomes easy. PTT.
Dr. Sapnil, are there any questions on chat box or YouTube? Agnivesh? Okay.
So yeah,
Excellent.
Again, primary arthrodesis is not an option.
Hemant, excellent case.
He had taken a few opinions for primary arthrodesis and he was not willing for it. And I think even after 4 months, if the articular cartilage is good enough, then probably we should give a attempt to try and salvage the joint.
Hemant, thank you. Unshare your screen.
Even if you have for primary arthrodesis, first you have to reduce the joint. So reduction of the joint is absolutely essential before even attempting an arthrodesis. The first step is right. Reduce the joint and see what happens. Again, primary arthrodesis, I don't think is an option here. You wait for arthritis to develop, if any, and then you can always think about doing.
Parag, who is next?
Yeah. So thank you, Dr. Hemant. Now, Dr. Hital is next. Hital, are you around?
Yeah, I am here.
Okay.
So, thank you, everyone. So I know we are a bit late in the talk, and I'm going to present a short and a simple case of non-union proximal humerus. This 56-year-old woman, she had a fall in neck humerus, and this was the first X-ray when it happened. It happened in North India, and she was fixed with this close reduction K-wiring.
Hetal, please enlarge the screen.
Okay. Sorry, one sec.
Play.
Yeah.
Press the play button. Yeah.
Just give me a minute. I need to get this out of the way. Okay. Is it okay?
No, not yet.
So wait, the window is in between, so I cannot approach it. Just give me another shot. Give me a minute. Once, let me stop sharing, and then I share screen.
Attention, Vishal Kundani, I have sent you the literature on osteoid osteoma. Please show it to all.
Sorry.
1.5 to 2 centimeters is the size.
Attention, Dr. Mukhi, sir. I have already replied you back on your WhatsApp.
But no, reply to everyone.
So Dr. Mukhi mentions that 2 centimeters is the size for osteoid osteoma, but he forgot to mention that osteoblastomas are also starting from 1.5 to 3 centimeters in various places, plus deformed pedicles, larger sclerosis.
This literature is very evident from Italy.
Dr. Mukhi, sir, please. You can discuss later on at the end.
So this was the fixation done. And
no, Hetal, no, it is not.
One sec. I don't know. Mode. There is a window. Okay, fine. Now I think I should be able to do it. Just give me a minute. Yeah. Okay.
Yes, perfect.
Yeah. So this was the fixation which was done elsewhere. And of course it failed. They removed the wire and the patient presented to me at the end of 2 years with this picture. Yeah. This was 2 years post the primary surgery, the fracture and the fixation. Now, any suggestions on what we can do about this? This is a CT scan. You can see there is some bone left. The tuberosities are with the head fragment.
I would fix it and graft it.
Okay. Fix it. Okay. So this patient had gone to
the head of humerus shows an empty shell, then don't attempt to fix it. But it still shows good cancellous bone in the CT scan.
Yeah. So the patient had gone to many people. Of course, they had someone had advised reverse shoulder, someone had advised hemiarthroplasty. There was a complete week of weakness of elevation and abnormal mobility at the fracture site, of course, on a clinical examination. So what we tried to do is we scraped out the open reduce and we put a fibula. And we tried this Arthrex plate where it's a variable angle. You can change the angle. We tried to put but only hold we could get is in the anterior fragment. So this was the kind of fixation we had. Unfortunately, patient had lost the immediate post-op X-ray. But what we did was we reinforced the whole thing. The cuff to the plate. We repaired the cuff to the plate. We took 5 number 5 ethibond sutures and repaired the subscapularis and the supraspinatus to the plate. And this is the picture at the end of 5 months. This was a picture at the. I thought it was primarily fixed in varus. But the fibular graft has taken well. And you can see the clinical picture right at the end, even after 2.5 years of the injury. Patient could reasonably elevate, happy. You can see her rotations are not bad. And she had a very good forward elevation. And she had good strength. You can see this internal rotation was good, and she could do the job test, shows a good strength. It is definitely like, so here the contention was, first thing was, but this salvage was challenging. The surgery was long. So at the end of the surgery, with the kind of osteoporotic bone and fixation, I thought whether RSA would have been a easier way out. And how often can we get lucky with such kind of fixation? Or we should trust biology more than our prosthesis. So this is what the discussion I wanted to have, whether it was just a one-off case or this is routinely this can happen, that if you try to preserve the biology, fix it well, even with the osteoporotic bone, we can get lucky with the healing. So this is, I would like to know from the house what each and anyone has a different opinion. Anyone would
can you share your screen and the last X-ray once again? This is not a normal outcome where the head has dropped in so much of varus.
Yeah. So unfortunately, I don't have the X-ray post-op. Usually, and this patient was from out of town. So the post-op X-ray was something similar to this.
Hetal, with this picture, I still feel that it is not completely united.
Do a CT scan.
Okay. So, probably the fibula is holding that fragment with so much of varus, almost, like say 70 or 80 degrees of varus. The head shaft angle is not an acceptable one. And with an improper view, she may be holding with the screws or with the fibula. But to say it has completely
the X-ray on 28th May 2018, somehow the patient was out of, then she went away. She came to me last year, 2020, and she came for some other problem, not the shoulder problem. And I happened to ask her, how is her shoulder? She said she has no complaint. So what we are talking right now is this result is not 5 months. This is a year later. So a year and a half, 2 later. So functionally, she had no complaint. I asked her to do the X-ray, but then she was very reluctant to go to the X-ray this and all for the purpose of because of the pandemic. And she said, I am okay with that. I don't want to do anything. And so that is how. So of course, a CT scan or an X-ray would be good. But right now, the patient is completely symptom-free and happy. So she's not ready to do anything.
Right.
PTH will help her.
Yeah, Parag.
Yeah, so Hetal, fixation is not a bad idea. My only point would be that fibula also is required. So you have to construct the central, lateral, and the medial column. So at last, Vyrock had presented a case where I had done a double plating with the fibula. So here, your fibula, once you put in, you have to double it well into the head and make sure you get as much valgus as possible on the head. At Wrightington as well, we used to do this for these non-unions with a relatively younger patient. So they do heal. Attempting fixation, if the patient understands, is not a bad idea, but I think you should have got more valgus onto this. And sometimes you have to put a small medial plate as well to buttress and prevent excessive varus. And of course, suture ankles to the rotator cuff to enhance that valgusization. So I think
where will you put the medial plate? Where will you get the proximal holes? Hold in the medial plate.
So what you do is when you put the medial plate, you get 1 or 2 screws into the head and then 1 or 2 screws onto the medial side. So, I'll show the case which we showed at Vyrock last year. So that's an option, double plating. It's not very common when you need it, but in complex 3 parts, 4 parts here as well, if you felt on table after the fibular strut, it was still going into varus, you would have seen it. Your GT is very high riding here. You see where your GT is, your head would look in gross varus on table as well. But any case, if it is...
This is the picture which was on C-arm.
Yeah, so this is an abduction view. What you need is, again, just in neutral with a touch of external rotation. And you'd have seen that this is soft. And
it's just normally standard how we take after post-op. We just see if the screws are proper. So this is not a really abduction view. This is just a standard this. And after fixation, it looked fine. So probably slowly, maybe over a period of few months, it may have slipped into some varus.
Also, you have only 4 screws in the proximal fragment.
Yeah, but we could not get. We tried to pass many screws, but then you see if the screw is not holding, no point putting them. So we just removed. So this is the best we could get. No, these are 5 screws. 1, 2, 3, 4, 5 screws. So, but if you don't get a hold on a screw, you don't tend to keep them. You just remove them. So we tried to put more screws, but this is what we got at the end of it. And it was a shell of a bone. It was a very, and these are mentally challenging. You are at the end of surgery. You don't know whether it is going to hold, it's not going to hold, it's going to fail, especially after 2 years of surgery. So maybe I got away, maybe I should have done a reverse shoulder. Anyone who would do a prosthesis in such cases, because harvesting such a long fibula and doing the fixation and all, it's a long surgery. It's a longer surgery than you would need for the replacement for a reverse shoulder. So would it have been a better thing to do a reverse shoulder in this?
She's just 56, Chetan.
Exactly. Yeah. So this, so that is what the attempt was, to just see if it can work. But a failed surgery is a failed surgery. If this doesn't work, then patient would not have probably come back to me. So this was the last chance.
Would you have considered putting a structural femoral head graft, which would have given you much more stable reduction rather than a fibula, which is very small in diameter, considering the head of the humerus?
Femoral head graft means I would get a irradiated bone from Tata and put it.
Either that, or
I would rather use a good fibula which I have harvested from the patient immediately during the surgery. Then
I'm talking about the stability part of it. Because
probably the fibula is acting like a second plate.
Second plate, yeah, I think so. Because
I was asking about either fibula head or structural graft filling the whole of the defect to give more stability.
The irradiated graft will just not work in this particular situation. It is only meant to fill cavities, not for using as a graft.
Chetan, what he means is, like, you curate out the sclerosed bone and pack that with as much as cancellous bone or the allograft as much as possible, so that to have improved screw purchase. That is what he was meaning. Am I right?
I am extremely sorry I missed. We have put a cancellous graft also in this. Sorry. That was also there.
And give PTH also.
Yeah.
Good case, Hetan. Good case. Can you close?
Excellent.
And unshare your screen?
Yeah.
Okay. Thank you. Next, Dr. Vishal, are you ready?
Dr. Sai Raut is presenting the case, sir. I am here.
Okay.
Good afternoon, everyone. I hope my screen is visible.
Yes.
So it's a case of L1 compression fracture. So I would like to tell you the history. It's a 63-year-old male. He had a history of fall at home, presented to us with back pain. He had tenderness over the L1 region. He had no radicular pain. He was non-ambulatory because of pain, and his neurology was normal. The MRI and CT images are as follows. He has an L1 fracture, where the CT scan also shows the L1 fracture. This is the axial cut where we see a right-sided laminar fracture. What next? In such fracture where there is a L1 fracture with no neurology, how do we go ahead with this? Do we fix long or short, or do we put an interfragmentary screw? And with that, do we decompress or just fix and leave? So I would like to go ask if they have any opinion about it, about the L1 compression fracture. What would they do here in such cases?
This is a case for conservative treatment. There is hardly any collapse. Most of these are compression fractures. Till in case it collapses further, in case over a period of observation of 3 to 4 weeks, there is persistent pain, I won't just treat it conservatively.
Agreed. Completely agreed with Arvind, and I think this is what we followed. This patient was followed up for 3 weeks. He was just not able to even move in the bed, and purely because of pain, with absolutely no neurology, even at 3 weeks of conservative treatment. And he started developing a serious amount of pain. And that's when we discussed the option of fixing it. Now, question is, when we fix it, shall we do it a long segment fixation, or shall we do a short segment fixation? What would you usually do in such case scenarios where there is a L1 burst fracture? And if you do a surgery, short versus long, and whether you use an interfragmentary screw or not?
Yeah, did you repeat an X-ray after 3 weeks?
This is the CT scan at 3 weeks, actually. We never did a CT scan before. So if you see, there is already a Humerus kind of thing happening there. The CT scan was done at 3 weeks.
So I don't agree that there is Humerus thing happening right now.
Yes,
just a superior end plate fracture. If he has persistent pain, I would at this point think of vertebroplasty.
Right, right. A male patient with yeah.
So we had given the option of conservative and fixation both to the patient, and patient had opted for the fixation, and we did the fixation. We went one level above and one level below, and we do the 6 screw construct here, and we did not do any decompression here. We followed all standard protocols. We did short stabilization for this fracture, and we mobilized him early, and we also protected him with brace. But now patient was when mobilized and discharged post-operatively after 10 days, he came back to us with inability to walk and with a right-sided weakness, which was right-sided foot drop. So what did we miss here? And what do we do next in this case?
Did you do a biopsy, pedicular biopsy, while before putting the screw in the burst fracture?
No, sir.
Sometimes a solitary plasmacytoma presents in this way.
First time we did not do any biopsy, sir.
ESR was high?
No.
Nothing.
Probably in the absence of injury, Dr. Mukhi, we should have done a serum protein electrophoresis.
All that was done. All that was done. I think so. This was a fully worked up case. He's a male. Remember, he's a 63-year-old male, had a fall from stool of 4 feet height at home, and that's how he developed this fracture. The idea of pathological fracture ran into our mind. In fact, it's a red flag. Any fracture above 60 years of age, we worked them up absolutely in detail. And myeloma profile, tumor profile, PSA levels were all normal. MRI was screened and discussed with the radiologist that there is any soft tissue or anything. There is no soft tissue there. There is no ballooning of the vertebrae. And it was a classical traumatic oblique osteoporotic fracture in an elderly male.
Now do a Mars MRI or a myelo-CT.
So do you have axial X-rays, axial CT or MR? I mean
Yes,
CT?
We have. Yes, that's
Post. Just to rule out, the fracture, the screw impingement. Can you show the X-rays again?
So this patient was discharged absolutely normally. He started walking the second day, and it is only at 2 weeks when the patient came back.
Okay. So it was a delayed foot drop.
Exactly. So delayed foot drop at 2 weeks, which was like a mind-boggling surprise to us. Why did this happen at 2 weeks? What is happening? What did we do wrong? So that the first surprise was at the end of 2 weeks, when patient is here for suture removal with us, patient is mobilizing only minimally here and there. What did we do as a mistake? Did we opt the wrong patient? Did we do a wrong surgery? Screws are right in place. Is the short segment that has failed, and could we have prevented this by doing a longer segment, or we have missed a diagnosis altogether? So this was the question in our mind.
Mars MRI and CT myelo.
Yes, so we did an MRI. Sir.
Yeah.
That's the MRI, which doesn't show too much of compression there. The dural CSF is completely intact around the conus as well. And remember, patient has only foot drop, has got no knee weakness, no hip weakness, which doesn't correspond to the L1 level, and only foot drop at this point.
Anything happening at L45, L5S1, axial MRI, fresh event?
Yes. So we saw it in axial as well. There is nothing at L45, IS1. Only right-sided ankle weakness, one-sided ankle weakness. And what do we do now? I mean, this is the MRI and the CT scan.
Also, CT scan shows all screws in place and everything. There's no impingement, no compression as
and
such.
No halo around the screws as well. So we don't expect that the implant is loosened in 10 days time. So what did we do wrong? Why did this patient suffer?
One thing I can think of, which I have seen prior also, if you put screws in the level where it is fractured, what happens is your screws are just lateral to that superior fragment, which has come posteriorly. In a way, we are kind of stenosing the canal iatrogenically. Maybe over a period of time, if he is an osteoporotic patient, some degree of micromotion plus these screws, which have probably pushed the superior fragment posteriorly, might have caused some degree of weakness.
Yeah. So possible. But what the question is, aren't we regularly doing these procedures of using an interfragmentary screw in burst fractures with stable PLC? Isn't that a norm in patients with A2 type of fractures with normal PLC intact? I have been doing it for years now. I'm sure everybody of you do it for burst fracture. Interfragmentary screws are very regularly used.
Yes.
So should we stop doing it from now? So should we stop doing it from now onwards? This assumption of Arvind is very valid. I mean, this could have easily happened. Not that we were able to correlate the CT and post-operative MRI.
I've seen 2 such patients with complications with the late onset weakness, and I stopped doing this. putting screws at the same affected level.
After this surgery also, we have done at least 5 more trauma patients. We have still been very happy with using interfragmentary screw. So I mean, that is a subjective call, and there is enough literature to support that in type A2 fractures, interfragmentary fracture fragment screws really do enhance the stability when you're using a burst fracture with less than 30-degree kyphosis.
No, but this was inherently stable. As I said, vertebroplasty would have been enough in this patient.
So yeah, I mean, that is a debatable thing. In a male with an end plate fracture, I would really be doubtful using a vertebroplasty. In a young male patient, end plate fractures, I think vertebroplasty is a strict contraindication in my books.
No, I don't think so, because if you drop the cement in the anterior 1/3, and this is superior end plate fracture,
So do you want to see
is
the CT
intact.
again? Sai, can you bring the pre-op CT? We'll show
Right
you
side laminar fracture also.
And end plate fracture also. Can you see that? There will be cement lying in the disc all the times.
No. So this usually the routine case where we do vertebroplasty. In the anterior 1/3, if you drop the cement, and so this laminar fracture these are all senile burst fractures. They usually have some degree of posterior third fracture as well as laminar fracture.
So my concern was this soft tissue in the behind the L1 and the retropulse fragment with posterior end plate fracture. And in these cases, I would really use a word of caution of using any cement in there. So why did it fail?
Post-operative bleeding? Had you kept him on Sclexane or Ecosprin?
No. Patient doesn't have any blood thinner.
No. Okay.
So what next, sir? Now from here, what next?
We don't know the cause, the infection. Maybe we went short. What we went wrong? Early mobilization, osteoporosis, SNSA, or all of these. So we got an X-ray done later on, which shows some back out of the screw, which we see here. And we went and did an EMG NCV, which again showed the chronic motor axon degeneration. We repeated the EMG NCV also. Again, same. There's no any proof of anything. And post-op 1 month, when we saw the neurology started worsening, patient had right ankle and knee also grade 1. Then left ankle also started affecting. His bilateral hip was also 3/5. And then sensations were all intact. Reflexes were all normal. We did an MRI again after that, and this was the picture, MRI picture for the patient.
So any idea what went wrong? Patient came to us at 3 weeks post-op. We had no correlation of the symptoms to the radiology, and that's why we hold it. And this is where we landed, that this patient has worsening neurology now.
Any weakness in the upper limb?
Nothing. None.
Did you take any neurological opinion if something else was happening?
Three neurologists, including the Dr. Singhal Saab also.
And
we all feel that there is nothing happening in the spine in terms of mechanics.
Did you do any dynamic X-rays?
We did one X-ray. Now patient is immobile, cannot do anything now.
Do a myelography CT.
That we didn't do, sir, unfortunately.
Did you do a CT alone now?
Yes. Just before this, we had a CT where the screws showed. Sai, can you go back? Yeah, this is the CT scan. This is at 4 weeks post-op.
Vishal sir, can I make a comment?
Yes,
sir.
Yes, Agni.
Sir, if we go back to the pre-op CT,
yes.
I feel there is a vacuum or a Kummel's in the disc also.
Yes.
So the instability was not only at the vertebral level, it was also at that disc which we were sort of targeting.
Agreed.
And we can see that posterior sort of bridging osteophyte or something forming over there.
Now Agni, you have mentioned the thing. Now tell me, if this same patient comes to you on day 1, how different will your surgical plan be?
Sir, if hindsight is always 6/6, but first seeing the CT, I was also of opinion that we need to reconstruct that disc as well, and not only the posterior column. This was the first thought which came to my mind.
Okay.
So maybe something anteriorly load sharing or something.
And now what do we do? We are here, patient is neurologically worsening. Should we go operate and do this, decompress it wider?
Some enhancement is also seen around the screw.
Yes.
Do we have the axials here?
No, sir, we don't have axials here right now. So we don't know, probably maybe all the reasons and all the segments and so like Dr. Agnivesh mentioned, it was a case of where there is bridging osteophytes and it's a case of Angstpon or inflammatory arthritis. Short segment probably does not work. So we went and retrospectively analyzed and studied the CT again. And then we thought that maybe in such cases, short segment does not work. So we went ahead next time and we saw there was some screw loosening. We went 2 level above and 2 level below the fracture site. This was the immediate post-op X-ray after the second surgery.
Any decompression done?
Yes, sir. We did a wide decompression at
Wide
this time.
That has to be done. Yes.
And one of our screw on the right side was loose on the top. The D12 screw was loose. It just walked out.
Yeah.
It just walked out. But all the other screws were absolutely intact. So the message here is that in burst fractures, when they happen in elderly patients, a short segment, which is a norm. So let me bring this to you that the A2 kind of fractures where the kyphosis is less than 30 degrees, the norm is to do a short segment instrumentation, and it will always remain so. However, there are some modifiers which we missed out in this particular case, that the modifiers are if there is a posterior column injury, number one, like in this case, there was lamina fracture. Number two, if there is significant osteoporosis. In all these cases, one should not attempt a short segment instrumentation, and long segment instrumentation is a norm. Osteoporosis, seronegative spondyloarthropathies, and patients with even slightest of column injury in the posterior column, short segment fixation is contraindicated. This is the message that probably we have learned from this failed case.
3 screws above and 3 screws below is ideal. Not 2
in a osteoporosis, yes, I would completely agree.
2 screws again, you will fail.
The message is that short segment instrumentation does not work when there are modifiers. What are these modifiers? Any kyphosis more than 30 degrees, significant osteoporosis, any amount of bony column injury in the posterior half, and a kyphosis more than 30 degrees. Please do not do short segment fixations in trauma patients. You are bound to have a failure of the implantation.
That's the message we wanted to give, and already told by Dr. Vishal. Thank you so much.
What is the chance of failure again?
Can you unshare your screen? Dr. Raut, can you unshare your screen?
Very high, sir. We have counseled the patient about this.
Thank you very much. Parag, who is next?
Yeah. So, now in the interest of time, I think the second half we are starting off with Dr. Aditya Khemka. So very quickly, we'll go through our cases. Instead of 9 minutes per case, I think we'll try and keep it to 5 minutes. So we overrun by 10 minutes, but at least we'll finish at 1:10, 1:15. Is that okay with the EC Council?
No, there is no need to complete the whole list.
Okay.
We can have fewer cases and have a good discussion rather than just completing it.
Okay. So we'll continue with the order till the one, and then we'll call it quits.
Right.
Okay, Dr. Aditya is next. Are you there, Dr. Aditya?
So we can have the interesting one amongst the lot which are remaining. Parag.
Yeah. So Dr. Aditya had not presented any so far. So
yeah.
Are you with us, Doctor?
Can you all see my screen? Can everybody see my screen?
Yes, we can.
Yes, we can. All right. So I'll go through the case quickly. So just in the interest of time, so I'm presenting a case today with a TKR and a severe intra-articular deformity. So just this 42-year-old female with bilateral knee pain for 5 years, which has increased over the last 6 months. She's not had any history of trauma, injury, twist, known case of rheumatoid arthritis, on treatment for the last 15 years. Now she's having pain in all her daily routine activities, doesn't have any other comorbidities. So she came to me, this is what the knee looked like. So we're only assessing the left knee for this particular case. So this is what the knee looked like from the side, from the front. So this is what it looked like just before I started the surgery. So she had a fixed flexion deformity of about 20 degrees. Further flexion was possible up to 90 degrees. She had obviously severe joint line tenderness, medial and lateral, as well as a clap test positive. This is with a further flexion. The deformity disappeared in further flexion. This is what the X-rays look like. So she was a bilateral knee tri-joint osteoarthritis with a windswept deformity. So right now we're talking about the valgus deformity in the left knee only, which was about intra-articular deformity was 33 degrees. So obviously I had to assess the extra-articular deformities as well in such a patient because she was a short-statured 42-year-old patient. So I did consider that. And there was femoral shaft bowing in the sagittal plane and tibial shaft bowing in the sagittal plane. But apart from that, there wasn't any coronal plane or rotational deformities. So we assessed that with CTs and I actually got a bone model constructed in order to help me plan what I was going to do for her. My initial plan was to do a primary knee, and I could achieve this. I put the stem just to prevent any post-operative loosening. I didn't feel that the bone was any weak or anything, but this is what the post-op X-rays look like. This is how she was walking on day 1. So I started immediate weight bearing for her. She obviously struggling with her right side, but due to various constraints, we planned only one knee at one time. And this is what she was doing at 6 weeks. So she's struggling with her right knee, but the left knee, she's walking reasonably well.
Aditya, can you go back? You said intra-articular 33 degrees of deformity.
Yes, sir.
Okay, and can you explain that? Where exactly is that deformity then? Your bone model doesn't show significant bone loss.
No, sir. So this is a standing X-ray. So exactly what Dr. Mukhi was talking about initially. So on the standing X-ray, there was 33 degree deformity intra-articularly. I'll actually go back to a video which I did.
No. Can you explain intra-articular deformity? What do you mean by that?
So the intra-articular deformity is solely in the coronal plane in the joint. So when you make the mechanical access from the femur and when you calculate the mechanical access from the femur and the tibia, the deformity is actually intra-articular rather than in the femoral shaft, the tibial shaft.
No. The issue is whether it is in the soft tissue or because of the severe bone loss of the lateral compartment, or a hypoplasia of the femoral condyle, lateral femoral condyle.
So there was definitely. So I'll go back to that X-ray.
No, your bone model doesn't show any of that.
Yes, sir. So if you can see the X-ray actually
the 3D,
shows
the 3D model. Can you come to that?
Sure, sir.
So here,
it is
neither. Yeah.
So this bone model is actually showing that there was a hypoplasia of the lateral condyle, and it was a fixed valgus. But it is not showing as much as a 33 degree deformity, which I found on a standing X-ray.
Yeah. That is what I'm saying. So it is not correlating with the tibial loss or a hypoplasia of the distal femur. Now,
but then CT was not. CT was not a CT.
Now, where was the correction achieved? In the soft tissue or in the bone? Can you go to the next X-ray?
Yes, sir. So the correction was achieved by an asymmetric resection of the bone, which is an intra-articular asymmetric resection, and by ligamentous balancing in the joint itself. So there was no correction which was done extra-articularly. So it was a combination of ligament balancing as well as asymmetric intra-articular resection.
No. Can you explain what do you mean by ligament balancing?
So
because here probably the IT band was quite tight, and then
yes, sir.
LCL.
Yes, sir. So the principle is after an asymmetric resection. Sir, I'll just take the liberty to go to another slide later. So there was this,
and the post-op X-ray still looks in some valgus. It is
yes,
not fully corrected.
No, sir.
No, go back to the patient's X-ray. Yeah.
Sure, sir.
Yeah, here.
So I have retained valgus, but leaving it in 6 degrees valgus at this stage gave me a very good balance medially as well as laterally on the soft tissues. That's why I didn't.
Do you have a scanogram at this stage?
Sir, unfortunately, I've not been able to source.
Okay, just hold on. Abhijit, are you there? Abhijit? Mukhi sir, your comments?
Can I have a lateral view?
Yes, sir.
See, she will start getting stress fractures at the tip. That's my prediction.
So tip of the tibia, tip of the tibial stem?
Prosthesis, the stem.
Yes, sir.
And she'll start getting pain there.
So should I have put a smaller stem?
No, just show me the skyline view.
So these are the only two views that I have.
Because the patella, I still feel, is causing some pain, may cause pain.
Okay.
Because it is below. That is,
yes, sir.
yeah, one. And second, it is not resurfaced. So you have a 15 to 20% chance of anterior knee pain.
Anterior knee pain.
Yeah.
Okay. So there was a little bit of Baha. That's why I didn't decided not to do a domed patella. That's why I decided not to replace it and not to do a domed patella.
Yeah.
Because I felt that the articulation would not be that great.
Yeah.
Go
Excellent
ahead,
job.
please. Go ahead, please.
So the learning points.
Hypothyroid?
Sorry, sir, please.
Is she hypothyroid?
Yes, sir. She is hypothyroid as well.
Yeah.
So the learning points for me in this particular case was I wanted to do the least possible thing I can do for her, but I wanted to assess what her status is intra-articularly as well as extra-articularly. So I went through the entire literature. I did a review of literature wherein I decided what would my approach be. So this was based on when I actually read the literature. A Cochrane review actually told me when is this extra-articular deformity significant. So I found that it was 5 degrees in the coronal plane and 10 degrees in the sagittal plane. So in this particular patient, there was a femoral bowing as well as a tibial bowing, but it was less than 10 degrees. That's why it was considered as non-significant. That's why I didn't approach any osteotomy or any other thing. Like in these patients, the deformity is much, much more. So that's why when we have to address the extra-articular deformity as well. So the options that any of us have, I felt, was TKR with asymmetric resection, TKR with osteotomy, and or distal femoral replacement. And all of them had their advantages and disadvantages. So just wanted to present this, which is this Wolff's law, that is an asymmetric dissection actually leads to a laxity of the lateral and the medial collateral ligaments in their own spaces. So we have to be actually wary and balance the soft tissues nicely in order to prevent this laxity from happening. Like you can see in these slides. So violation of collateral ligaments is the most important.
Thank you. Thank you very much, Aditya. Can we move to the next case?
Yeah.
Any follow-up of that case?
So this is, she's at 3 months and she's doing reasonably well without any anterior knee pain for now.
Good. Thank you. Please unshare your screen. Parag.
Yes.
Yeah.
We can have 2 more cases if you finish fast.
Dr. Hemant is there. Hemant, are you around?
Yeah, I'm ready.
Okay, fire away.
You want to present the same case again?
More discussion should be generated. Right. A case of large intrapelvic hematoma causing sudden weakness, paralysis in a patient. We had a 78-year gentleman. He had a COVID and he had gradually progressive left aortic movement. And one day he just couldn't stand up and collapsed. Previously, there was no history of any trauma or any neurological symptoms or any radiating symptoms or so. But he was admitted for COVID and he was given Clexane 0.6 BD for 5 days and then OD. He had an ultrasound also was done and it was normal on admission. So on examination, so there was a marked weakness in the left lower limb. Hip was 2/5, knee 2/5, 1/5, and EHL was 1/5. Otherwise well-oriented and normal patient. Hip, knee, joint, spine, there was nothing abnormal found. So his EMG was done and there was found to be a axonal loss. We did a MRI. MRI showed a large intrapelvic hematoma on both sides, but his symptoms were only on the left side. So this was a lumbar plexopathy because of the large hematoma in the pelvis following anticoagulant treatment. So he could move, this is a pre-op, he could move his right leg, but he couldn't move his left leg. So we did our incision above the iliac crest and a kidney tray, almost half a kidney tray full of hematoma was removed.
and he started recovering from next day. And we could see that his power in the foot and toe is improving. Previously, prior to surgery, he couldn't stand because he buckle up. Now he's able to stand, but his quadriceps are still weak. But toe power and foot and ankle power is returning. So we did a literature search, and lumbar plexopathy is an uncommon cause, and various causes which can happen. It's hip dislocation, sacral fracture, diabetes. Various causes have been described. And in our case, it was a large intrapelvic hematoma, which had caused this sudden weakness.
Due to Clexane. It's better to
Yes,
give Ecosprin.
And with the recent COVID, so a lot of anticoagulants have been, being used. So we should be aware of such a cause. And in epidemiology, diabetic have about 4.2%, and in neoplastic also can cause a lumbar plexopathy. Pelvic sacral fracture also have an incident. In delivery also, 1 in 2,000 to 6,000 cases of lumbar plexopathy have been found. So it's a rare cause of sudden paralysis, and because of the anticoagulants, and MRI would detect that extent of the hematoma, and he would require a prolonged physiotherapy for recovery. And early surgery would be there to remove the pressure on the lumbar plexus and hopefully for the recovery. Presented for a rare presentation, rare cause.
Ethan? Yeah, I had exactly a similar case, very similar case of severe intrapelvic hematoma post-COVID admission. But he didn't have that much of deficit, but of course it was painful. We put him on steroid and some rehab, and he completely recovered. So I was wondering if, since it was acute, you could have put him on a steroid, and probably this patient would have recovered without surgery.
Because it was so large and the paralysis was so dense.
Yeah, so this hematomas are very scary. If you do MRI in them, they look like as if they are covering the hole, the muscles are involved, it's inflamed, it's like a scary doomsday picture. But that patient, surprisingly, within 2 weeks, he started walking without even realizing that he had any pain 2 weeks back, something like that. So probably steroids would have also done the job.
Hetal, in fact, on the contrary, see, I had a similar patient who denied surgery, and that time we had done a review of literature, and then it suggested that even if it is late, you should go in and decompress. It causes some kind of a compartment syndrome. The earlier, the better.
That's my agreement, and he has done a good job. I accept it. Don't wait.
I was wondering if there is a much more minimal access way of decompressing it, retroperitoneoscopy or ultrasound guided.
Yeah, when it is such a large hematoma, it is better to get your hand in, go up to the brim and remove what you can.
You have to cut the psoas sheath. Moment you cut the psoas sheath, you are decompressed.
Yeah.
Like a compartment.
Put him on a vac as well to, remove whatever remainder which would, get collected.
I had a similar case in the spine with Clexane.
Okay.
She was operated for lumbar spine, given Clexane 2 times. She presented with foot drop, paralysis, retention of urine. Immediately we opened up and she recovered. Another case which was not opened up by my colleague has gone into retention of urine and not recovered. So don't wait. When there is nerve damage, don't wait.
We are talking here about peripheral nerves, not spinal cord.
Even peripheral nerves anywhere, wherever there is compression of the peripheral nerve, acute compression, decompress it. You're a surgeon. Why you want to wait?
So you are a surgeon, not a barber. What I want asking is that this is a huge pelvic space where there is a peripheral nerve. Spine is a tight space where a small amount of clot can cause severe compression. Here there is a huge, it has a huge space to accommodate hematoma. Hematoma, which is because of acute bleeding, is a soft structure. It is not a strong this thing. So it's just a way of treating. My experience is this. So just because you are a surgeon doesn't mean you have a you have to hold the knife in hand and keep cutting everything. So that's not the, I don't agree the similarity between a spine and a pelvic, acute pelvic hemorrhage. There is no similarity. This peripheral
literature search suggests that you should go for a early evacuation for a hematoma. So that's
in
what the
spine,
literature
I can
search.
understand. In spine, you have to evacuate.
No, in the calf
pelvic
also.
hematoma.
Compare apples to oranges.
In the calf also, compartment
suggests that we have to decompress.
Cross talks, please. Now, Heman,
yeah,
they're known to recur, like as Hetal was saying. You
now,
evacuate.
hopefully it will not.
You understand. Any retroperitoneal hematoma, like even the one which we see in pelvis fracture, we evacuate them, and again it refills.
In this case, the anticoagulants have been stopped, so hopefully it will not recur. We have not done a further ultrasound or a further MRI to reassess whether it is filling up or not, but we'll be monitoring with the EMG and clinical recovery.
INR and FDP.
Yeah, it's normal.
Yeah.
And previously also there was no comorbidities.
Yes.
So hopefully, INR and APTT will remain stable.
Right.
Okay. Dr. Sangeet, let's go ahead. One more last case to have time for?
Yes, we can have that.
So Vishal, are you ready?
Yes, sir.
Okay.
So this is a case about Anderson lesion, which is commonly heard, rarely seen. And it poses some very interesting diagnostic and management dilemmas. Just to bring out a history, there's a youngish 57 male with moderate build, has been having chronic low back pain off and on with morning stiffness for ages long, and recently had a trivial fall a couple of months ago. And only recently has he started going off the feet, has been becoming not able to walk because of imbalance that he's been feeling and has presented to us. And on examination, there's a round back kyphosis with tenderness, and lower limb power, particularly in the knee, has been documented to be going down. On examination, patient has hyperreflexia, bowel bladder activity is normal. He is able to walk with minimal support there. And that's the kind of X-ray we see, which shows a erosion in the D11-12 area with the opening up of the vertebral body there. We did standing, lateral, and supine and X-rays, which shows the opening of the deformity there.
The red arrow
itself says he's able to see better because his gaze has improved while he's lying in the bed. Earlier, he was not able to see the roof. Now he's able to see the roof after this fracture. And that's the kind of MRI. And what I want trying to highlight here is that there are multiple small nodes here and a lot of edema, and you also see a bit of soft tissue around. And the first thing, like in this case also, he was diagnosed to be called to be a spondylodiscitis and was kept on AKT by an orthopedic surgeon in the close vicinity because of the radiological picture that documents that there is a lot of edema, a kind of discitis kind of picture there with mild soft tissue in the perivertebral area. This looks like as if it's a spondylodiscitis and can easily fall you into a trap of calling it a spondylodiscitis, which commonly in our country is called tuberculosis because of the triad of radiological finding. But to highlight this, it is not a spondylodiscitis in a patient with ankylosing spondylitis, known history. You do a CT scan, you will see a completely fused spine above and completely fused spine below with sclerotic margins there. And it's a very well-known entity that despite the erosions, this particularly despite raising a suspicion of either TB infection, but it is commonly known as Anderson lesion. And Anderson lesion is nothing but a hypertrophic non-union of a bamboo oblique fused spine in a patient with a known seronegative long-standing spondyloarthropathy. And it is very classically described as, because it functions like a long bone hypertrophic non-union, where there is a lot of granulation tissue, you see a lot of callus around, you see a lot of edema around because of the segment above and segment below. The fracture is the only area where the movement happens, resulting into a hypertrophic non-union. And it is also called aseptic discitis, which is purely because of the granulomatous lesion, which causes the disc erosion. And this is not something that is tuberculosis, and AKT is a wrong way to go ahead. If any doubt of suspicion because of increased soft tissue, a biopsy is primary and should not be thought of as a tuberculosis treated empirically. The doubt always here is that whether we should do a 2 level above below or 3 level above below, and whether we should do anterior reconstruction. Previous literature has shown to be shown that anterior surgery is the way to go in these patients. And there have been papers from India, and including Mumbai, where anterior reconstruction and anterior bone grafting was the only way out in such patients, thinking that the anterior column has failed, and that is why anterior column has to be reconstructed. And that also gives you a chance of deformity correction, which again now is very well proven that it is a long bone which is behaving into a hypertrophic non-union, and that is why the principles of hypertrophic non-union have to be followed. It doesn't require anything but a long segment fixation, 3 above and 3 below, like it was done in this particular case scenario. And it's only from the posterior approach that we went in and did a graft. If you can insert graft there or a cage there. If the defect is more than 10 millimeter, I usually prefer a cage going in. If the defect is less than 10 millimeter, then I think only a graft, chip graft is more than enough. One point, all these patients have a round back deformity. It is highlighted in multiple literature that do not try to do a kyphosis correction at this time, because the cord is extremely sensitive, and any attempt to do either a VCR or a pedicle subtraction osteotomy or a lure, that because it is opening up, I might as well correct it and open it up completely so that the patient's kyphosis also gets corrected. It is recommended to do under correct these deformities. Otherwise, the implant failure chances are high, and these patients will end up having neurological deficit. So Anderson lesion, a great mimicker of tuberculosis because of radiological finding, behaves like a hypertrophic non-union and requires treatment like the principles of hypertrophic non-union long bone fracture fixation, which is long segment fixation instead of a short one. And now there is growing evidence. Our paper just came in December 2020 as well, which shows that posterior only approach without correction of the deformity is good enough, and circumferential fusion, if possible, is the ideal approach for Anderson lesion. Thank you so much, sir. Open for discussion. We have multiple such cases. Just to show you a few of them, some MRI pictures which resemble tuberculosis, but again managed in the same manner. Another case scenario, again showing a tuberculosis like radiological picture, but the treatment is, it is an Anderson lesion, and the classical point is a patient with a fused upper spine, fused lower spine. Consider it as a Anderson lesion before you really think of it in terms of spondylodiscitis.
I fully agree with you, Vishal, but still do a biopsy when you're putting a cage in.
Yes.
Because
yes.
in India, the chances of TB are still there.
Yes.
With ankylosing spondylitis.
Yes. In fact,
so
there is a paper
at the same time.
There is a paper on Anderson lesion from India itself. 21 Anderson lesions were biopsied. One was found to have tuberculosis associated. 20 were found to have no tuberculosis, and it's a aseptic discitis. But still, it is recommended during surgery, go and take the sample, and the sample should be sent for histopath and culture sensitivity. However, the message is that do not fall trap to the radiological findings. It is a clinical history of seronegative or positive spondyloarthropathy, and radiological finding of a fused spine above and fused spine below, the fracture in between is highly likely to be Anderson lesion. And no short segment, no 2 above below. It is 3 above below, like we do in long segment hypertrophic non-union long bones.
I think some 10 years back or 15 years back, Dr. Mukhi has presented one such case, and Samir Dalvi has also presented one such case in one of the clinical meetings. I don't know what is a follow-up, but do they all heal well once stabilized?
Yeah. Exactly, sir. They behave exactly like hypertrophic non-union of long bone, where you don't even need a graft. You just stabilize them long segment and don't put a graft. It is like Angstpond hip fractures. Even in hip fractures, if a Angstpond patient has had a hip fracture, they will heal like anything. They fuse like fire. In 3 months, you see solid bone there.
Something like a spontaneous fusion.
Exactly, sir. So don't worry about the defect size. Just stabilize them long.
I used to do wiring at that time when there were no pedicular screws available. And that was the case there. He was operated 3 times with posterior decompression, anterior fusion, all failed. And we did posterior wiring and he completely healed. At that time, there were no pedicular screws. Long segment fixation.
So thank you very much. We come to the end of this clinical meeting. I must thank Dr. Jhunjhunwala sir, who has been throughout attentive, Dr. Mukhi sir, who have given us so much of time and experience and opinion on each one of the cases. Thank you for all the speakers who have presented one after another excellent cases, and our webmaster Kshitij and Agnivesh, who have helped us in conducting this meeting online, sponsorer Sun Pharma, and all the EC members here who are present for giving us support with this. We come to an end. Final comments by Parag. Are you there, Parag?
Yeah. Can you hear me?
Yes.
Yeah. No. Thank you, BOS, and thank you, the EC Council, for getting us on the rotation. Hope to see you all at VIROC again, and long live BOS.
Thank you. Thank you. Only one question to Vishal, that broken probe can act as a navigator. Am I right in thinking?
Agnivesh, can you stop recording and let both of them speak?
Just for
Till
a
the
second,
desire.
stop recording
Till the
and I will-
desire.
Let
will
all of
also-
us-
Vishal.
let all of us sign out and let them speak.
Yeah.
So I'm ending the
Recording has been stopped. We all are leaving.